Instruction 3, we are now going to mingle. Let's get mixed up. Okay? So we mingle as we move around, shaking hands. And then when I say 2 by 2, you make sure you stand with one person. So you're only a group of 2. If I say 3 by 3, it's the 3 of you. And we see who are the odd ones out. Okay? So let's clap our hands and sing, and we mingle. And we clap our hands as we mingle, and then I'll give another instruction. Okay, let's go. Mingle, mingle, eh. Mingle, mingle, eh. Move, move. Mingle, mingle, eh. Mingle, mingle, eh. 3 by 3. 3 by 3. 3 by 3. Who are the odd ones out? This is interesting. We've got all 3s. Very good. Okay, let's do it again. Mingle, mingle, eh. Make sure you are not in the same group with someone you know. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. 4 by 4. 4 by 4. 4 by 4. Okay, so we are seeing there's a group that has 2 people and that has 6 people, like Chi. What happened to numbers? I thought you were talking about numbers yesterday. Okay, we're going to do final round. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. You're not mingling enough. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, and I can see some people following each other. Let's mingle, okay? We've got to meet people we've not met. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. 3 by 3. 3s. 3s. 3 by 3. How many are you there? 3 by 3. 3 by 3. 3 by 3. Are we all in the groups of 3 by 3? Can we spread with your group members? Just spread. Give yourself a space. So everyone has 30 seconds to tell each other what they've learned or what they learned yesterday. 1 minute. 1.5 minutes. Okay, so everyone just make a small circle amongst yourself and tell each other what you learned yesterday. The participants who've just joined, please come down. Can we hear from you as well? You are 3 of you. Let's make our group and recap from what we learned yesterday. I believe everyone has had the opportunity to speak. Have we finished? If your group has had the opportunity to speak, all the three, please lift your hands up. That is finished. Only one group. The second group. The third group. Fourth group. 4 to go. Have we finished? Have we all had the opportunity to speak? Very good. Okay, let's mingle last time. Let's mingle one last time. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. Come, come, come. If you're joining us, just join the front. Mingle, mingle, eh. Mingle, mingle, eh. We're not mingling. Mingle, mingle, eh. Okay, hold on, hold on. There are people who are standing and clapping. The meaning of mingle is to get mixed. Okay? Okay, let's mingle. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. Mingle, mingle, eh. 8 by 8. 8 by 8. 8, 8, 8. 8 by 8. 8 by 8. You're 8. You need 2 more people in that group. One more person. Do you want one person from this group to join that group? Dr. Priscilla, please join that group. Okay, so hold your hands. Please hold your hands. Hold your hands. Hold your hands. Can this group please move this side? Can you move this side? Give yourself a space. So I'm asking you a very simple question. Is it possible? My question is it possible, while you're still holding your hands, to give yourselves the bugs without releasing your hands? Is it possible? To turn around without releasing anyone's hands and still be holding your hands like that, while maintaining the circle? Yes, like that. Is it possible? Okay, so go back. Go back. You see, no one is crossing anyone's hands at the moment, not even their hands like that. You're all holding each other like this. So I want you to just turn around, not releasing any hand, and still be holding your hands like that. Discuss. All I can tell you is it can be done. So discuss amongst yourself how to go about it. So at the end of the day, when you started, you're not holding each other like that and like that. You know, when you discuss, and we are speaking about partnerships, we are speaking about synergies, you know, it can be done. It can be done. Okay, so this group has done it. This group has done it. And I'm happy the rest of you did not see. Hawakuachiana, mimi nimewaangalia. Sasa mnaona mikono ime cross namna fulani hivi. Okay, mikono cross namna fulani hivi. So please go back. You see, this group has demonstrated that it can be done. You only need to discuss. You want them to do it again? So at least you can learn from them. Okay, so first clap for them. Okay, so let's show them. Let's show them. Do you see they did not release their hands? Okay, so let's do it from our ends. Okay, let's see the rest of us. Very good. Don't release hands. Don't release hands. Very good. Very good. Uh-huh. Very good. And the final group? The final group? Okay. This professor group. What is happening there? Very good. So let's put our hands together. Now, don't release your friend's hand. Okay? This is the final exercise. You're in a group of 8 and 7, yeah? These are the lines, these are the people you're going to sit with the rest of the day. Okay? So without releasing the hand, professor's group, this group, take the first line, professor the second line, that one the third line, and that one the fourth line. Let's go to our chairs. Don't release, don't sit without anyone who is not in your group. Okay, let's go, let's go, let's go. You are sitting on the first line, second line, third line, and fourth line. Let's go. Let's take our seats. DJ, naomba ule wimbo. Take our seats. Let's warm up the room a little bit. How was that exercise? Did we learn anything from our friends? Did we add some knowledge? So how did Professor Wafwa end up on group 1 again? At least happy I know you're not on that group. Please go to your group members. Please go to those lines I had instructed us we go to. Please, it is important we stay in our groups. There are quite a number of group activities today. Thank you. Let's move. You know you're keeping us from starting the program. Please go to your group, the first group, the second group, the third group, and the fourth group. And I remember all the groups. At least I remember those who cracked the... Let's move, let's move, let's move, let's move. So as we get settled, I reckon there are new faces. If you know you came for the first time yesterday and you're joining us for the first time today, please stand up so that we may recognize you. Can we have the mic? Pass the mic. Is it working? Okay, here you go. Use this.
New York headquarters. I'm an SBCiE specialist there. So happy to be here.
Thank you so much. A round of applause for our colleague from the headquarters in New York. Asante sana. Any new member who either came yesterday for the first time or is joining us today for the first time? Okay, so we only have our colleague who is joining us from UNICEF, the headquarters. It's a short day today. Thanks to UNICEF. It's half a day today, and delighted to start the program. We are going to start with the moderated panel discussion that is going to look onto the role of social accountability, dimensions and modalities during implementations of social and behavior change in emergencies. This session will be moderated by... Is it Awet, are you moderating this session? No? Dr. Chi, thank you so much. So ladies and gentlemen, let's put our hands together once again for our very own Dr. Chi. Karibu sana. Bring the energy now. Why are you coming like... DJ, watu wakiwa wanakuja huo unawasindikiza na kawimbo. Huyu dada ni Makonde. Naomba nikukumbushe.
Thank you very much, Austin. Good morning. As Austin said, I'm here to moderate first panel of the day on thematic area number 5, which is the last thematic area for our dear symposium. It's on social accountability, conceptual dimensions, and operational modalities during SBCiE. So I'll quickly welcome the panelists to sort of set the tone for the thematic area. Of course, we'll later have a presentation on this and other issues on social inclusion from Dr. Egidius Kamanyi from University of Dar es Salaam. So the panelists for the session We have TIP, Asgard. We have Asgard, he's not yet in. Asgard. He's not yet in. Okay, and
we have I've seen TAP. Any rep from TAP? Come and share experiences.
okay, and we also have Lillian from Ministry of Community Development. Lillian is a senior social welfare officer responsible for MHPSS, mental health and psychosocial support. Welcome to the stage, Lillian. We also have Jerome Dimwaya from HelpAge. Karibu. I see we're supposed to have Dr. Hussein from MOHAS. I see he's not yet in, so they'll join the stage as they come in. Kaka Peter Mabwe from MOH, Health Promotion Section, please join the stage. We have a representative from Chavita. Did I see Kaka Dixon? He's not here yet. Okay. Do we wait for Kaka Dixon or she can? Okay. Thank you very much, Austin. So as you arrange the panelists, members of the House, you will all agree with me that social accountability issues, dimensions, and principles are very important to take into account as we advance towards impactful change in social behavior change in emergencies, or towards effective SBCiE interventions. And when we say social accountability in our context, what are the key issues that we are looking at? What are the tools that we are speaking about? Is it the participatory nature in different aspects of the health systems? Is it the involvement, the community involvement? Is it the engagement that we have been speaking about since day before yesterday? And of course, we're going to hear other speakers on that. So what exactly are we intending to speak about in terms, in relation to SBCiE in public health emergencies? So I will give an opportunity for the panelists to give us their insights on a number of issues. And maybe to start with, my dear panelists, how do you think social accountability contributes or has contributed to building institutional trustworthiness? Because at the end of the day, we are saying social accountability is the extent and the capacity of citizens to hold the state or to hold the authorities, their institutions, accountable, or the service providers accountable and responsive to their needs. Our communities as beneficiaries, are they able to hold us accountable? Are they able to ask us questions? Are we transparent enough to them? Do we involve them enough in when we are responding on we are on preparedness in emergencies we've been speaking about here since day before yesterday in terms of the all the infectious diseases we have been accounting in the country. So what are the levels of trustworthiness? Have we built trust with our communities? Have we built that level of confidence that is required? And what are maybe the practical steps for building it and implementing it effectively? When we speak about transparency, integrity, what are the practical steps? What have we been doing so far? What have we done so well, and what are we struggling to do? As ministries, Kakapita, you'll tell us well about that as Minister of Health. Again, as social welfare gurus, people from the Commissioner's Office, you'll tell us so well. If we've been able to give our community, provide our community with the confidence that they require. But again, our colleague from HelpAge, you can also tell us about this. You're dealing with the old gurus. How have we as the government, or have we as partners, been able to build trust to the communities of the old? Kaka Jerome, would you like to start on this? Karib San.
Thank you so much. Talking about social accountability, I think this is very important. As you mentioned earlier, we are talking about the way the institutions, the government is being transparent, is being responsive, and is being accountable, especially in the situations of emergencies. And there are a number of ways I could cite examples from the way we've been implementing, which are crucial when we want to ensure this accountability. First of all, we need to be transparent in information sharing. And when issues happen in the community, we really need to involve people to get to know what are the nature of the threats, if there is a threat, what are the preventive measures, and what are the available resources. Because when you inform accurately those who are targeted group, first of all, it makes them clearly understand what is happening, but also it is even easier to engage them in the interventions. So we need to be transparent in our project through COVID-19. What we did before commencing the project, we did an inception meeting which involved the various stakeholders, including the beneficiaries themselves, and we told them what is it happening and what resources we are going to use, who are we going to partner with. So all this information were clear to the target populations. And that goes to the second element, that you always need to involve the community. Community engagement is very important, because there is this saying which is very much used that for those beneficiaries, especially older people or those people with disabilities, you can't, there is nothing for us without us. So you can't just impose interventions to the community without involving them. You need to ensure that they're also involved and they participate in designing the implementation. But also you need to have some sort of a grievance and a feedback mechanism. Sometimes we tend to implement interventions, but to what extent are we monitoring community feedback in terms of what we are doing? What are the complaints? What are the steps which are being taken? And what is the communication loop, feedback loop, which is there to ensure that there is a monitored information and there is clear information. So it's always good to have that kind of feedback mechanism to ensure that the information shared between the two parties. But also in all these interventions, we used to have a partnership with other other partners which we engaged with, and it was important to share notes, to share experiences, and to have synergies among these partners, because you could see that we had a number of partners we are engaged, like through UNICEF project, but while we are intervening in one segment of the community, other partner could be focusing in another segment of community. But how do we compare notes? How do we share the experience? These were all important to ensure that synergy is maintained and that at the end of the day, we creatively share that social accountability. Maybe I'll stop that here for now. Thank you.
Thank you very much, Jerome from HelpAge. Now, to what extent have we really been able to sort of involve all the key groups in the community? Since day before yesterday, we've had a number of contributions from our colleagues from Chavita, representing the deaf community about social inclusion, ineffective social inclusion. To what extent, Kaka Peter, would you tell us that the government champions and the partner institutions or partner organizations champions have been transparent enough, have been inclusive enough in terms of different interventions, preparedness and responses in a number of public health emergencies that we have encountered in the country? Kaka Peter, would you mind giving us your insight on that?
Thank you, Dr. Chipole, for your questions, but also I thank my colleague who have just contributed on the issue. Yeah, the social accountability, I think it was also a priority, I can say, for the government in all the public health emergencies, and including the ensuring inclusion of all relevant groups. And citing an example, when the COVID-19, was declared in our country, one of the measures the Minister of Health took in collaboration with all partners was to establish, if you can remember, call center. So this was crucial in order to get feedback from community, so that community can be part of not only can be active participants in the implementation of preparedness, but also response on the pandemic. And this helped us to get insight, feedback from community, and also even complaints from communities and the other things like that one, which needed some immediate attention at various levels based on the nature of the complaint or issue on the table. So that one was one of the measures, but we have government structure at various levels. We have several committees which also were very active in making sure that all relevant segment of the population can have a forum for airing their views and the comment regarding any implementation of any emergency in terms of preparedness or response. And this is across up to the community level. We have several committees which are platform during public health emergencies, and most of them are working to give an opportunity for our clients or community to contribute actively to what is being implemented in terms of public health emergencies, but also to give their concerns which need attention, and that has been the case. We also, in the community engagement, we know we have various groups with the different needs. So in terms of SBC in public health emergencies, some, I mean, we had some interventions to address various groups. It might not be in that scale which should be, but at least we had some various targeted interventions for elderly, we had targeted intervention for people with disabilities, we had targeted interventions for children and the like. So this was hand in hand also with their participation, but also advice and opinions on how to improve the interventions. So I think in terms of transparency also, we know much of our intervention were also media based. If you can remember, the president by then called to all media to support SBC during that time. So we had so many interventions in the media, and our Honorable Minister also gave several press releases just to make sure people are regularly informed on what is going on. And you know, there was so many speculations through social media, you know, people are trusting, the trust between the government and the people. But at least the government did its best to clear most of the issues which were raised through social media and the other platform, through various regular press release. And if you can remember, the minister held several sessions to respond to media personnel on what is going on around the media. So I think even the issue of resources, we had our, you know, the Prime Minister's office, the multi-sectoral coordinator for the government sectors, so they also were on the front, and the issue of transparency and the resources, mobilization and the like were also transparently done. So to me, taking an example of some of the outbreaks or public health emergencies and social accountability, the government or the Ministry of Health has been doing its best to ensure trust for the clients who are the citizens, but also other partners, because we also work in collaboration with our partners. So there is also trust for among the government and the partners, but trust among the government and its citizens and beyond, even with the government and the international community. You know, we are not living in an isolation. So we had the government has the obligation for the international community, and it did its best to fulfill its obligation. So for now, I can end up here and give an opportunity to my colleague. Thank you.
Thank you very much, Kaka Peter, for citing many of the examples, including the call center. We all know that right information builds trust, and right information is very key in any public health emergency, whether preparedness or response. Colleagues, would you also cite examples of the forums or the structures that we have been using to engage, involve, and make our interventions participatory with the community? What have been the pathways? Is it the committees? Yesterday we had colleagues from the local governments, the municipals, sharing and explaining how well they engage the community. And we also had Mwenyekiti, the chairperson of all the street chairs, the 564 street chairs, street chairpersons of Dar es Salaam City. So could you please cite some of these committees that we have been used to increase access of weather information or anything about our interventions? Helpage. Lily, would you love to start? Okay. Karibu.
Asante, nitatumia lugha yetu. Mfano ambao naweza nikautoa, mfano wakati tunatoa huduma ya mabagi Kagera, tulihusisha watendaji wa vijiji katika kutoa huduma. Huduma zilikuwa zinaendelea kutolewa kama kawaida, lakini kuna changamoto za hapa na pale ambazo zilikuwa zinatokea, na pia katika kuhakikisha huduma zinafika ipasavyo, tukawa tunashirikiana na wenye viti wa vijiji kupitia vikao na kufuatilia utekelezaji, lakini vile vile tukaweza kugundua kwamba katika eneo ambalo lilikuwa limeathirika na ugonjwa wa Marburg, tukaweza kutambua kwamba kila sehemu kuna lifestyle yao ambayo huwa wanaitumia kuendesha maisha yao. Kwa hiyo tukaweza kugundua kwamba kuna waganga wa jadi ambao walikuwa wana nguvu sana katika hilo eneo. Kwa hiyo tukaweza kuwajengea uwezo, kwa hiyo na jamii ikaweza kushirikishwa kwa njia hiyo. Asante.
Thank you very much. So Lillian is citing examples of some of the key people and key communities that were involved. An example from the famous Kagera, that even traditional healers groups representatives were involved and reached with informations and all the interventions so that they could deliver the message to their network of fellow traditional or herbal healers. Jerome, would you like to cite some of the examples from your view?
Yes, thank you. In our case, we had a number of structures from the national, regional, and even to the village levels. We have what we call older people structures, older people associations, which are formed from the lowest unit called the village. And through these structures, they have a hierarchy which goes from village, ward, district, region, and to the national level currently. And these were very crucial structures which we used for our interventions, and they were in all project areas. And at the same time, at the regional level or municipal level, we worked with administrative structure at the region. We are talking about the councils, the CHMTs in these areas. We collaborated with them. The RMO office were also part of our partners, but also at the national level, we did work with, for instance, in the case of the COVID response, with the Resist National Committee, which was kind of responding or managing the crisis at the national level. So to have all these kind of connections at the national level, the regional level, and at the community level where we had to work with the older people structures, all these were kind of the pathways we used to communicate. Thank you.
Thank you very much, Jerome. So colleagues, if we recall from yesterday discussions, these are just a few that are cited here, but you will recall that from different partners, we had different forums. Go to TIP, we have the faith leaders networks and committees that were used to escalate the messages and all the key issues to all the faith leaders in the country from both religions, Muslims and Christians. And then if you go to if you take a system thinking, we have different committees starting from the village health committees or the streets health committees. Go to the facility, we have the health facility governing committee, and we had an example here from Zanzibar yesterday from Dadatima. So these are some of the structures that colleagues here are speaking about. Now, since Dr. Hussein is here, we would love to hear a bit on the knowledge management aspect, and if you could share examples or best practices from the previous public health emergencies that you sort of implemented in the area of social accountability. Did the study that you do, Dr. Hussein, in any way stimulate any of these aspects attributes we're speaking about here? Community involvement, community participation. Did it in any way stimulate the states or the partners, all the key implementers, or the policy people in any way to improve on that area? Karibu, Dr. Hussein.
Thank you, moderator. Good morning, everyone. So, with regards to knowledge management, we are aware that everyone generates information, and unfortunately, we do not normally disseminate the information to audiences or to stakeholders. And this is just very unfortunate because normally you find someone who is doing an intervention kind of, or a project, just to achieve the objective of the undertaking, without knowing that the information coming out of the intervention or the research is worth for knowledge seekers. There are always people who needs knowledge. There are people who needs to know new things every now and then. So putting knowledge in archives, in shelves, without dissemination is not helpful. We are here because we are sharing experiences, we are sharing undertakings, we are sharing lessons learned, and this is what brings us together here. So about knowledge management at our institution is something that we really needed to strengthen. So we needed to have knowledge management systems, in the sense that we can generate knowledge, we can generate information, but we can store knowledge. More important, we can use knowledge and share knowledge with colleagues or partners. The way I see, there is a gap, and that's why this time around you have seen that everybody's just talking about, this meeting is so nice, it's so successful. Is because we're lacking some platforms to share information, to share our findings. So, by the way, later on I'll be presenting on knowledge management issues. So this is coming at prematurely, but what I can say that it's important that we have platforms that we can share whatever we are generating. And in this case, actually, with regards to our undertakings in Ebola response study, we hadn't have any Ebola in our country, but we did an anthropological survey to assess the risk factors, social cultural issues. So if we do not have such kind of platform to disseminate this finding, how do you know that in Kigoma, for example, in Zanzibar, for example, there are social cultural issues that may exacerbate transmission of Ebola. It's just because we have generated information and we really needed to have a platform to share. This also applies to response studies, for example. As I mentioned yesterday, we did a response study in Kagera during the Mabag. So if we could not share the findings, actually it could have been, it could have been unhelpful to the government and to people who are responding. What is more important is that we do research, we generate information in order to inform the response. Therefore, it's important for us to make sure that we have platforms where once we generate information, we have to store them and make sure that there are people who are seeking such kind of knowledge, and we have to have somewhere to share the knowledge. I'll come later with my presentation. Thank you.
Thank you, Dr. Hussein. So last question, my colleagues, as we foster partnerships between our local authorities, our communities, the CSOs, and ensure collaborative approaches as we promote community participation in decision-making processes. Do we at any point take into account SBCiE, protection against social exploitation and abuse? At any point, we can start with HelpAge.
Thank you very much. SBCiE is very critical in these interventions, and it's always one of the key components we have to consider while we do these interventions, because somebody yesterday said it, that in everything you do, make sure that you don't do no harm. And no matter how much you are doing, how much interventions you are having to the community, if at the end of the day you don't ensure that these people are protected in any kind of abuse, then that way that interventions wouldn't be real viable. So ensuring SBCiE is preserved or is maintained is very critical to any feasible or appropriate intervention. Thank you.
Thank you very much, Jerome. From the government side, SBCiE, protection against abuse, sexual exploitation and abuse, or any form of abuse. There's this call line from Ustawi wa Jamii. What's that they report abuse or anything, unyanyasaji wowote wa kijinsia. Lilian, ile ni namba gani ile? What's the number? It's 119. Is it 119? 116. 111. 911, that is for Professor Collins. It works in Professor Collins.
Nilikuwa sijaelewa swali. Namba, kama kuna namba za kupiga wakati wa kama mtu akitendewa vitendo vya ukatili, kuna 116, lakini pia kuna namba ya wizara sijaishika. Kwa hiyo tuna namba mbili ambazo tunatumia, naweza nikaitoa baadaye. Tuna 116 na namba ya wizara pia. Kuna call center kule, unapiga simu, unapewa huduma. Tunatoa huduma kwa makundi yote. Shida zozote, usuluhishi wa ndoa, watoto walio katika watoto walio katika mazingira hatarishi, wazee, yani hatari yoyote ambayo katika jamii tunatoa huduma. Asante.
Okay, thank you, Lily.
Lakini pia tuna kamati katika jamii za ulinzi na usalama kwa mwanamke na mtoto. Lakini pia kama wizara tuna program mbalimbali. Tuna program za fit person ambazo zinazuia unyanyasaji kwa watoto wakati wa majanga. Ni program ambayo ni walezi wa kuaminika ambao katika jamii wanachaguliwa na halmashauri, wanajengewa uwezo. Kwa hiyo majanga yanapotokea wanaweza kukaa na wale watoto na kuwahudumia mahitaji yao wakati changamoto mbalimbali zimetokea.
So from The Commissioner of Social Welfare, there's a call line, 116, and she's even telling us that you can even call to report other issues like GBV, other issues other than sexual exploitation. GBV, even marital issues, she's telling us. We'll hear about that more from our colleagues from the subnational level, where the committees are sitting, the committees that she's mentioning, and the Fit Persons program. So let me open the floor now for contributions and questions. Karibuni sana. Let's start. I'll start with, there's a hand here, there, Professor Nyamhanga, and 2 other hands. So we'll take for Austin, if you allow me with the time. Let's start here, because he's here for the first time today. He wasn't here day before yesterday and yesterday. So our colleague from the States, from the headquarters, we say karibu sana here. You're welcome.
Yeah, thank you. Thanks so much for this session. I've learned a lot just listening to all the experiences that have been shared. Because social accountability traditionally, has been like implemented in the development sphere. So if we talk about social accountability in the emergency setting, these applications are hello. All right, I was hearing some feedback. So okay, cool. So I was saying, like most of the applications of social accountability has been in the development sphere. So it's interesting to hear of stories from the emergency context. So my questions and comments. One, I think I did hear the involvement of media, which are very important as interlocutors in social accountability processes. And I would like to hear more the role of civil society. And also when we talk about accountability in emergency context, like most of the conversations are around like accountability to affected people, which involve humanitarian actors as opposed to state action. So now, because that's the caveat with social accountability. And social accountability, as we know, it's part of vertical accountability, which is really about holding duty bearers accountable through elections or things like those. But we also have horizontal accountability between like different state actors, and I've seen some models which combine like state actors and also bottom-up approaches and top-down approaches, like having like a combined approach to social accountability. So I just want to ask, like, what's the potential for that model in the emergency context here in Tanzania? And secondly, I just want to hear some success story, if there's any, in terms of some issues that were identified through social accountability processes, and what were those issues, and what happened, and what were the tools that were used? Because traditionally, some ability, like we have scorecards, we have social audits, we have budget analyses. So those, those typical tools were used. And yeah, let me stop there. I'll come again if necessary. Thanks.
Hope you're taking that, panelists and members of the House. So that was the first hand. Second hand, Professor Nyamhanga, karibu.
Yeah, thank you, Madam Chair. I wanted to talk about, comment on the knowledge management, and I want to link what Dr. Sena has said on knowledge management with what has been spoken by other speakers, Peter and the other colleagues there. What I want to say is that knowledge management is really key. Knowledge management is key in responding to emergencies. So I want to know whether there are management structures, knowledge management structures at the community level. We can call them community-based management system or community-based knowledge management structures where they are there, because these are really key at the community level, whereby the community people can generate knowledge which will guide now decision making and the planning in preparedness for emergencies. Thank you.
Thank you. Thank you very much. Third hand, Dada Swai, karibu.
Thank you very much. I just want to share a bit about Dar es Salaam to give you the picture of Dar es Salaam, talking of social involvement during outbreaks. You know what happens during outbreak? Taking the example of Tanzanian, there are many people who go through media and they can get the information even beforehand. But as we know, we have the diplomatic rule and the strategy at the state level, of which the press release should be given out at the state level. And for us at the regional level, we usually get the information and all the plan from our leaders at the ministerial level, PRH, about any outbreak. So after getting the information from the PRH and all the ministerial level, at the regional level, what we usually do under the RIMO, we usually orient the leaders at the regional level. We have the 14 departments at the regional level. So we usually call the meeting and orient them, the regional level and the district level, all the 5 districts, telling them about the outbreak and what is going on, where are we, where should we do. After orienting them, being the key leaders at the regional and the municipal level, the RC usually give out the press release of the outbreak. After the RC press release, we usually call the regional wazee. We have the old people, all the people at the regional level. We usually call them and tell them what is going on, because they have the connectedness and the collaboration with the many people at the society. So we usually give them the orientation. After giving them the orientation, we usually orient the journalist. The journalist is before even the press release, so that they can know what they should tell the society about the outbreak. We usually guide them. You know, the journalist should be guided in relation to the healthy protocols. So we usually give them the training, awareness, and tell them everything about the outbreak, and tell them when are we going to expect the press release from the RC, so that they can know what to tell, what message they should deliver to the community. Though after there, then we usually call all the teams at the district level, from the healthy, RCCE, logistic, all of them, we give the orientation. And after giving the orientation, we'll remain with the coordination team. Each coordination will have the team, the time to orient their team. And for the RCCE now, what we usually do, we usually call the meeting with the district level, the wazee, we have the wenyeviti, the leaders of the street. We have 564 streets with the leaders, but we have 102 wards. We usually call the meeting for the wards chair level people and the street chair people, telling them what is going on. And we usually give them the message to tell the community about the outbreak. How should they behave? How should they prepare? How should they go around? So after giving them the information, they are the one to work with us. Everything come in, we just communicate with them. But the RCC do go up to the community level through CHW. We have the trained CHW 620 who are trained for emergency and other health condition in Dar es Salaam. These are trained ones. But we have others who are not yet involved, but in case of the emergency, we usually use all of them. We call them to the body, we train them, and we give them the message. How should they go and give the information house to house? We need our people to know what is going on, and they should be able to answer all question which comes around and communicate with us in case there is a problem, maybe they cannot answer, or if they found that there is an outbreak and they should give the information to us. And then in case of the schools, we usually call the ward executive officers. This is what we did and we usually do through the district. We call the ward executive officers, we train them about the outbreak. After training the ward executive officers, we usually call the head teachers and the educational health teachers of every school through the ward executive officers. And then the RCCE team, we usually divide ourselves, go to this, because we asked the ward executive education officers to call the head teacher and health teachers from every school under his or her ward.
Asante,
so
asante,
for us, we
that's
go
why,
and
please
supervise them.
wind up.
So we go up to the community level through faith-based and everywhere.
So
That's
that
what
is
we do in Dar es
top
Salaam.
down.
Thank you very much.
So that is top down, that's why.
Yes.
Okay. Let's take the last hand.
Okay, thank
Karibu.
you. I will keep my
1 minute.
question very brief. I was meant to ask, how do we build the trust to the community? And what do you think is the impact of using police, for example, in intervening whatever that is going on? Because we have seen that, for example, in COVID, the police were used to sometimes beat the people who don't wear the mask. So what do you think is the impact of this in actually making the community trust in the interventions? Thank you.
Thank you. There's a hand from Chavita. Okay, 1 minute.
Thank you very much for availing me a minute to talk. Thank you all the panelists. I have been given 1 minute only, and I'll do just very quickly comment. We are discussing about sexual exploitation and abuse here. But I would like to know from the ministry, do you have any mechanism to make follow-up or to monitor what is going on in juvenile prisons? Because the hearsay says that their hearsay says that there are a lot of sexual exploitation and abuse in the juvenile prisons. But during humanitarian emergencies, people do live in camps, and there are children there and women, and those with disabilities are there. So how do you monitor such situations? You also said that there is a call center that everyone who has encountered a problem can call through that call center. But there are people, for example, for us deaf people, we cannot call because we don't have access to hear voices. So what are you doing in such a situation? What your plan to make sure that the call centers are also taking into consideration the issue of accessibility for persons with disabilities? I would like maybe to say that it could be accessible if deaf people could have an SMS center to send their complaints, because otherwise they won't call. So it's important for you to consider about accessibility of your call centers, because we don't call and we cannot hear. And sometimes if you use an interpreter, it's not safe for you because he might maybe freeze the statements. Thank you.
Thank you. Thank you very much. Now, panelists, let's start responding to the questions. I think let's go one by one. You can respond to any question you're comfortable with.
Thank you. Let me say something about the question.
Let's be quick,
yes,
in the name of time.
Yes, about the question by Professor Nyamuhanga. He was asking whether there are system for knowledge management at the local levels. So I think what Mama Swai was presenting here, actually it is part of the knowledge management. And people might be doing a lot of knowledge management issues without knowing whether this is knowledge management. So maybe my colleagues who are implementers can say more about how do they transfer knowledge from maybe one street to the other once they have evidence. Are they learning, are they sharing the experiences? Are they sharing the lesson learned? What are the new issues that are informing the public in terms of maybe prevention, in terms of control of the emergencies? So those are the kind of knowledge issues.
Thank you, Dr.
They might be doing, but without knowing whether this is knowledge. Thank you.
Thank you. Jerome, do you like to respond to any of the questions?
Yes, I would like to respond to the role of CSOs in terms of social accountability. I think here the civil societies have been very key in ensuring that they are becoming a watchdog in the community and therefore ensuring social accountability. You know, for instance, in the case of COVID-19, truth be told, there are a lot of issues associated with the denial of the situation, but downplaying the severity of the problem, but also even misinterpretation, where you regard the authority opinion vis-a-vis expert opinions, and all these created sort of confusions among the public, but it's the civil societies and in the great extent who came forward to say, you know, what is happening, what's actually happening in the community, and that way it helped to shape the information flow, the content, and come to the sorts of advocacy in what need to be done. So really civil societies together with the government have been together in ensuring that social accountability is key. Referring to the issues of how we build trust, I think for me, there are several elements which need to be taken into consideration. Transparency is key. Effective communication is also key. Honesty in most of these things which we are doing. And relationship building. Yesterday we are talking about having relationship where partnership is required is also key. So without this element, we could use police, we could use force, we could use, other punitive measures, but we can't effectively make impact if we don't involve people using this trusty method element. So those are my...
Thank you very much, Jerome. And I think, Jerome, that also applies for the tools. It's a partnership between the government and the CSOs, because CSOs have been really playing a crucial role in terms of supporting the government on these social accountability dimensions and measures in our communities. So CSOs are really frontline on this. The models again are top down and bottom up. I think later when they are all done and it is not mentioned, we'll cite maybe one example. Dada Lilian, would you like to respond to any of the questions? Karibu.
Asante, nilikuwa napenda kujibu swali alilouliza mwenzetu kuhusu juvenile justice. Kwamba tunafanya kwenye eneo la ufuatiliaji na tathmini. Napenda kulijibu hivi kwamba mahabusu za watoto zinaendeshwa kwa kufuata sheria ya mtoto pamoja na kanuni zake, Lakini vile vile katika ufuatiliaji na tathmini, ndani ya mahabusu kuna kamati ambazo zimeundwa ambazo zinasaidia kufuatilia huduma ambazo zinatolewa kule ndani. Lakini vile vile kwa level ya wizara huwa tunafanya supportive supervision kila baada ya miezi mitatu kuhakikisha kwamba huduma zinazotolewa kule za marekebisho ya tabia kwa watoto zinazingatiwa miongozo na sheria iliyopo. Asante. Call center katibu mwenzangu.
Okay, call center Kakamabwe will respond.
Okay, thank you.
Can you also translate a bit of what she said in one sentence?
Thank you, Doctor. Maybe to add on the issue of call center, yes, it is for now it is a challenge because as a madam from Chavita has just cited, but we have looked, we have noticed that way, and currently the Ministry of Health, in collaboration with partners, we are transforming our call center into contact center. So soon it will no longer be called the call center, it will be a contact center, whereby people could do text, normal SMS, but also WhatsApp, something like a WhatsApp chatbot, and then they can also call. So we'll be having like 3 options depending on the needs of a person. So I think once we launch, and hopefully it will be early next year, because the system is already in place. So there are few things technically which are being worked on by our technicians. Then I think once we launch it, it will help to address issue of people many who have challenge on hearing or impairment on the hearing, like the deaf community and the like. Even other people, we also have some people like the youth. The youth would like to chat. So probably sometimes they don't prefer to call. So it will be also an opportunity for anyone who is interested in any of the 3 options. Thank you. Maybe lastly, for Professor Nyamuhanga regarding the community-based knowledge management, I think currently the structure are there, and I think we have the community health workers, but we have the CBOs who are undertaking this we call community-based research. So I think, to me, the system are there, but they need to be strengthened. So I think the knowledge management concept needed to be well understood at various levels. And just like Dr. Hussein said, sometimes you might be not aware that what you are doing is a knowledge management or something like that one. So maybe we need to conduct some sort of orientation to all actors at various levels, from the community level up to the national level, and strengthen the whole issue so that we can benefit from the expected benefit of the knowledge management. Thank you.
Thank you very much, Kakapita. I think all our concerns have been addressed, and maybe to top up on that before I take Dr. Asina's hand, is that on the models, for instance, if we take only one example or only one aspect of, for instance, participatory planning, there's a very good system for that, although it has its own challenges on whether it works well or it doesn't. But participatory planning is, it's on the policy, it's on the guidelines, and some are implementing it very well. We have the planning process starting from the lowest level of either the facilities, maybe a dispensary in a street or a dispensary in a village, where the health workers in the facility would highlight the key issues that they would want, or the key activities that they would want to go through in the next financial year. And that takes into account the needs of that specific street or that specific village. And of course, the community health workers would come and would help them to understand the needs of the community. But there's also a committee called Health Facility Governing Committee. Those are sort of the watchdogs for the community. And these health workers really interact well with the Health Facility Governing Committee to better understand the needs of that particular street or village. So those needs are incorporated into the health facility plan, which later goes up to the, it's supposed to even go and be shared in the village health meeting so that people know this is our plan for the facility. These are health needs for the next financial year. And then it goes up to the ward committee through the ward health committee because the health in charge of the health facility, whether a dispensary or a health center in a ward, is a secretary or is a member to the village health committee meeting and the ward health committee meeting. So the mechanisms are there, but sometimes, as you may understand, they are not well implemented. And that trickles up to the council level, where now all the plans are collected from all facilities in a particular district, maybe 20, 30 health facilities, and they are all consolidated into one council comprehensive health plan. Yeah, so that takes also into account the bigger district hospital, and then the council health plans trickle up to make they trickle up and they're all collected by the region, and the regional health team, some members are here, they collect all the council health plan and they monitor the planning system, monitor the plans if it has followed the guidelines. So the systems are there. And then from the regional level, all the plans come to the ministries. The Ministry of Health and the President's Office Health Section, and they are all sort of assessed to see whether they have followed the guidelines and the priorities, and they are ranked and they are taken back. So the systems are there. The systems are really there to ensure that was just one aspect of participatory planning and whether people were involved and so forth. So the mechanisms are there. There may be challenges that are hindering the processes. Dr. Sina, I saw your hand. Half a minute before we conclude the panel.
Okay, thank you, Chipole. Thank you all the panelists. I just wanted to respond on the examples of the evidence-based tools or approaches on accountability. I work with the Tanzania Interfaith Partnership, and we usually implement some of the evidence-based tools or approaches, including the PETS, Public Expenditure Tracking Systems, where we usually track the funds from the national level to the beneficiary level. We produce reports and we share with the stakeholders. But also we implement the community scorecards, where we usually use to assess a plan and
mic on, your mic on.
We usually use community scorecards to assess, plan, implement, monitor, and evaluate our programs. Thank you.
Thank you very much, Dr. Sina, for that example on the SA tools. Thanks a lot. Now, the last question to my panelists, and the answer is probably a yes or a no on how well we do that. On the policy and legal frameworks about social accountability, how well have they enabled us to, do very well on the social accountability aspect? Do the policy give us that backup, the policy and legal frameworks? On everything we have spoken about here, community involvement, community participation, their engagement, transparency, integrity, building trust, social protection, the PSEA and everything in it. Do we have policy and legal backup? What do the guidelines, our guidelines, we are very good in guidelines, the health sector. Very, very good in guidelines. My friend, Kakamabwe. policy backup
Okay.
on social accountability.
Thank you, Doctor, for that. Maybe my colleague from community development will add more.
No, the answer is
We have.
how well.
I think
Is it there or it's not?
to my opinion,
How would you rank it? Okay.
we have the policy and the legal framework which supports social accountability, and to me, I think they are super.
Super.
Maybe, yeah.
Super. 70%, super 100%.
More than 90%.
Super.
Yep, well stipulated in place, capturing each and everything. So
The needs.
the needs, maybe my colleague can add, but we have all the,
Thank
the
you,
instrumental mechanism.
Thank you.
in
Lillian,
place.
in one sentence, super or bad? Not super. 95% super. Thank you. Jerome, from a CSO perspective?
I give it a 50-50. We are good at documentation, but not very good at implementation.
Good at documentation, implementation, 50%. Dr. Hussein, from the academia?
Availability, yes. Implementation, not sure.
Availability, yes. Implementation, not sure. So I'll leave you with who remembers the health sector strategic plan that said leaving no one behind, reaching out to all households. Who remembers that? And lunch is on me. Who remembers that? That was HSSP what? HSSP what? Lunch on me. Health sector strategic plan what? Come on, my health people. Health sector strategic plan what? 5. That lady's there. Your lunch is on me today. Thank you very much, colleagues. Thank you for listening. I think it was a wonderful panel. I will now line up with my colleagues for a group photo. And after that, Dr. Kamanyi, please prepare yourself and start moving to the stage. You have a presentation on social inclusion. Karib sana, please put your hands together for me and my colleagues. Dr. Kamanyi, karibu. Karibu, karibu Kamanyi. Karibu. I am, where's Austin? Oh, karibu, karibu.
Habari za asubuhi. Assalamu alaikum. Good morning. It gives me an absolute pleasure to invite Dr. Idigus Kamanye to the stage. Dr. Idigus Kamanye is a lecturer in the Department of Sociology and Anthropology of the University of Dar es Salaam and a coordinator of the Postgraduate Studies College of Social Sciences. Kimanye has done a research and a consultancy with a number of UN agencies and also in technical areas that vary from disaster management, that include governance, social norms, child and maternal health, HIV/AIDS, education, social welfare, community development, natural resource management, and he has an extensive experience in gender-inclusive studies and interventions. He possesses vast experience working with both local and international collaborators. He is also a winner of the Montpellier, I hope I pronounced that correctly, the Montpellier Advanced Knowledge Institute on Transitions, cohort of 2023. He actually returned back very recently from France after completing that. And also he is appointed as the member of the National Technical Working Group responsible for enacting the organ donation and transplantation law in Tanzania since 2022, working under the ministry responsible for this specific area, and also WHO. And he has recently received an appointment from the same ministry as a co-principal investigator in the implementation of National Survey for Violence Against Children in Tanzania, which is being co-led actually by UNICEF. He has published also a number of papers in the areas of livelihood, disaster management, with focus on how communities and individuals, including people with disabilities and other vulnerable population, respond to disasters. I had the pleasure of working with Dr. Kimanye in a specific project that we co-led, and this was around people with disability, and as it says in the screen, rethinking the inclusive exclusion of people with disability in disaster management. And this was the lessons that were gained from the COVID-19 response, working with the association, the Shavita Association of Persons with Disability. Please, karibu Dr. Kimanye to the stage. Thank you.
Good morning. Thank you very much, Madam Awet, for that introduction. And thank you everybody for the attending to this symposium, very important one. And this is the third day. It is good that we still have people in the room. Those with me who come from the academia know the last day always receives, fewer people than the first day. But today, it's good that we all are here. So my presentation, as has been introduced, is on rethinking the inclusive exclusion of people with disabilities in disaster management. And we are taking lessons from the COVID-19 project that was implemented by Chavita, the Tanzania Deaf Society, funded by UNICEF. And this is just, part of the results that we had, and it's the paper that I'm developing with the colleagues. So I wanted to take you a little bit first on what we observed. I want to make sure I am doing the right thing. Yeah. So maybe I proceed while the technical team is working on this. So I am talking of inclusive exclusion. I'm so happy that my work has been made a bit easier by the previous panel, because they have discussed in details what I want to point out. And in their last comments, they have talked very well about the presence of frameworks, guidelines, laws, acts, and everything that is important to make sure that there is inclusion. The Minister of Health and other ministries in Tanzania are very well prepared in terms of having important documents, having very important, inclusive approaches when it comes to what is documented. I was happy that we actually, had people pointing out how they rate how these documents are being implemented in practice. So what we find out from this study is that there is a realization that while we have very good documents, we have very good guidelines in place, especially those that make sure that people with disabilities, and in this case, the deaf, are involved, especially in disaster management plans, or, the whole cycle from, preparedness, mitigation, response, recovery, and rehabilitation, and everything. We have guidelines that make sure that all people with disabilities are involved. And actually, they are not just guidelines. Some of them are even legal, frameworks, which not just direct, but they just demand that we have to be inclusive enough. But what we find out is, while we have those good guidelines, when it comes to action, things are a bit different. So now, it is important we consider and rethink about what we call inclusion in this, in this accord. This is what I call inclusion, very well included, and nobody's going to raise a voice. Now, how about the practice? Completely excluded in many accords. So the COVID-19 pandemic taught us a lesson. When it happened in Arusha, Mwanza, and Mbeya, where this project was conducted, there was, as we know, there was a lot of frantic move at all levels globally, from WHO to all the institutions. Our government was part of this frantic move, with trying to make sure that we respond responsively, to make sure that everyone is safe. There were a lot of preventive measures that were put in place, including, like social distancing, as you know, hand washing, mask using, and many other issues that were put in place and were being enforced in a number of ways. When it came to the people with the disabilities, particularly the deaf, communication was in many ways a challenge. And under this, I would want to point out the root of the problem. One, the number of the people with the disabilities, especially the deaf, as mentioned by by the chair of Chavita yesterday, because of the nature of this disability, it's very difficult to know who is deaf and who is not. As you know, some of us have seen when we go out for lunch, for breakfast, I have seen people trying to communicate with their colleagues without understanding, their disability. Like on the table, and somebody says, that's easy. If they are not looking at you, they will not be able to know what you are communicating. So when it comes to understanding their disability, the numbers, the areas they live, residences, is not very well established. And on this point, we have tried so much to know the exact numbers of the deaf community. In some of the regions, there is, kind of anecdote information, I would say. There is no concrete data, statistics of how many they are and where they are and how they fare. So during COVID-19, for those, and another point, there is a lot of cultural stigma when it comes to deafness and other disabilities. Our cultures, very unfortunately, in many ways, in almost all ethnic groups in Tanzania, kind of find it shameful to have somebody with a disability at home. And because of that, the people with disabilities have always not received the same attention as the non-disabled people. They lack education in many ways. They lack presence and representation in most of the social services. So during COVID-19, the implementation was general. The communication was done, as we have heard, through the social media. And now, it's good that we have the interpreters. For instance, we have the sign language interpreters today, because this is special and they have prepared it for that accord. But during COVID-19, I am not sure if we remember how many times we had interpreters interpreting. But remember as well, how many deaf people have the access to television, for instance. Most of the information getting to rural areas and most peripheral areas is through radio stations, local and international, at the national level. The deaf community cannot comprehend, radio announcements. At the service centers, and in this point I would like to mention almost all service centers where they have to receive the services. Particularly for this public health emergency, it was for the for health facilities, all the way from the community health workers, CHWs, to the dispensaries, health centers, district hospitals, all the way. Now, we know in our own situation how many health centers have materials that are friendly in terms of communicating the information. I think you have seen when they interpret, COVID-19 is called, Mr. Simba, you can help me on that. Good, something like this. By the time COVID-19 erupted, did we have a symbol, a sign to communicate COVID-19? When did we have this one? Who was responsible for instituting that? What materials did we have at the end of the day? Until UNICEF came in at some point and decided to implement a pilot project. This was just 6 months pilot project for only 3 regions, under which I did the evaluation. And what they did was partnering this one for impactful change. And what they did what is actually written in the guidelines. It's unfortunate that it's not moving. I have the guidelines, one from the United Nations Convention for the Rights of People with Disabilities. We have another, we have ratified that as a country, but the Minister of Health has also guidelines. And in one of the guidelines in the People with Disabilities Act, we have for 2010, that we have a guideline which is on, I think, part 7, which is straight, directing all the social service centers to make sure that people are trained, the service providers are trained to provide service to people with disabilities, and particularly the deaf. And you remember, in the past, I think, 4 or 5 years, the country accepted to be commemorating the International Deaf Day, all right? And I remember I was in attendance when that was opened up. So COVID-19 comes later. How many service providers at health facilities are equipped to support and, care for people with disabilities, in this case, the deaf? How many? Do we have the number of nurses, receptionists at hospitals, doctors who can communicate? Actually, the study has established, these are some of the guidelines I was talking about. I just copied and pasted. No rephrasing. You can read them by yourselves. For instance, look at the Tanzania People with Disability Act, what it is trying to recommend. And this is just one. It is all over the documents. But at hospitals, police stations, in the court, we have the one-stop centers, the social welfare departments. How many are equipped to understand, to comprehend, and to communicate back with the people with the disabilities, in this case, the disabled. So during COVID-19, a lot of information just was, you know, these people, the people with disabilities, especially the deaf, were just expendable because they didn't know mainly what was happening, especially the majority. Very few, I'm not trying to generalize things here, but very few were able to know what was going on. Because some of them, for instance, I would say, the colleagues in the room might be, you know, lucky that they have children who went to school and therefore could translate to them. Because as you can see, they need support from interpreters. We have also accepted as a country, sign language to be one of the recognized languages. I think you know that, all right? It is a recognized language in use. But how many service providers have the ability to communicate in that particular language? How many have been trained? UNICEF did the training. They took a number of nurses and other service providers, including doctors, during the COVID-19 in the eve of 2022 for the 6 months, took them, in one of the area in Morogoro, trained them for 3 weeks on sign language and the basics and the basic communication to make sure that at least when they go back, they could service and provide service to the deaf. And what happened, the study found out that when the deaf realized there are people, service providers, who can communicate with them, there was a lot of them responding, not only for normal social services, but most importantly, of what seemed to be a challenge in most of our, in our country, vaccination. The deaf showed up very much, and they were vaccinated in huge numbers in Mbeya, in Arusha, and in Mwanza, where they recognized that there were people who could, you know, communicate with them. So one thing I want to point out again is the deaf, for instance, are very sensitive when it comes to communication. If they try to communicate to you, and they have actually shared experiences, reaching at the desks for communication, for services, and they're trying to communicate. They will find somebody who is older than them, they will do something like this. This means shikamo. Good morning. And this person will be, it means something different. And he will try and, you know, like these service providers say, hey, my friend, can you come and talk to this person? I don't understand. And then this person, I don't understand. You know, they go back home, they tell other friends, please, the services are not friendly. So in terms of inclusion in the documents, there is a very good inclusion. In the practice, these are the experiences I'm trying to share with you. Could you say they are included? I am trying to pose a yes-no question. Could we say with confidence that the deaf and other people with disabilities are included in disaster management approaches? You know, I was thinking of doing some kind of experiment before coming here. I don't know if the MC could allow me. I wanted to act, you know, I wanted everybody of us to act. Some of us, at least 2 types of disabilities, to just act. One, close up your ears to make sure that you don't hear anything, all right? And to some of us, just make sure you cannot see. You are visually impaired, okay? Can we try that? And I am sensitive, I know what this would mean. I need some of us to close up their eyes completely to make sure that you are visually impaired. And some of us to just, you know, make sure you don't hear anything. And I would like the MC to, not the MC, the DJ, the people, the technical team, to just give a bang of the like of an earthquake. And I would be happy to see the reactions. I didn't prepare them. I would just wish if they had that bang, like boom, and you react. I am taking you to an imagination. What do you imagine would have happened if an earthquake happened, we have visually impaired, and we have the deaf? What would have happened? The visually impaired would hear the bang, and they would feel, everything. The deaf, certainly, maybe they might feel, but they could not hear the bang. What would be the repercussions? But we are saying the first responders, the fire, brigade and everybody should be trained to make sure that they can manage disasters with the people with the disabilities. Would that happen in this room if we were in that situation? Thank you so much for listening.
Thank you so much. Thank you so much, Dr. Kimanye. Now we are going to open the floor for any comments, additions, or questions that you'd like to pose to Dr. Karibu. Okay, Shepherd, please.
Thank you so much, Professor Gideas, for the insightful presentation. I think I really enjoyed it in its entirety. Just one thing that I wanted to ask. In your title, why do you use oxymoron by phrasing it as the inclusive exclusion of the deaf? What does that mean? Thank you.
Thank you so much. Dr. Peter Mabwe, over to you.
Thank you, Madam Wawech, and I'd also like to thank Professor for his amazing presentation. Mine is not a question, but additional or advice. With the experience we had last month, we had an activity design workshop with our colleague Chavita and WHO support. So initially the activity was meant for production of SBCiE material for promotion of COVID-19 for people with for the deaf community, because we wanted them also to get the message and the benefit and ultimately to vaccinate. So in the course of the process, we learned that we had so many other needs, so we achieved it to produce material for the promotion of COVID-19 vaccine, but also we went further beyond that and worked also on the El Nino preparedness. We have a threat of El Nino, but also our colleague had so many needs. We went up to the cholera, routine immunization, but also the reproductive health, particularly the danger signs during pregnancy and maybe after delivery and so on. So what I'm concluding here is that we need the collaboration we have seen in this symposium and the partnership we learned, it needs to be felt here. So we need collaboration, partnership for partners to support on the issue of material, so that we can have the sign language material for our colleague. So we have so many areas which are untouched. So I think with this symposium and because we have so many key partners here, they can support. At the ministry we have the health promotion section. It has a production unit with a studio with modern equipment, and we have the capacity as we did last month. So we have at least now material with the sign language on various issues, but the need is very high, and we are working collaboratively with Chavita to try to mobilize more resources for the undertaking. Thank you.
Thank you very much, Peter. I think that's a very, very important point. Professor, I think we'll need to pick this up in the recommendations. Over to you, Professor Davidson Munadofa.
Thank you very much, Professor, for the presentation. I have two parts that I just want to make a quick comment, and then I have a question. I think this is a very difficult area to work in. My experience in Liberia in 2014, at the height of the Ebola outbreak, we were directed to a school for the deaf. And as WHO, UNICEF, and MSF, and others, the partners who were in Liberia, we went there with the hope of trying to bring information on Ebola. And when we got there, the thing that hit us first was obviously we didn't know sign language, but how do you communicate the word Ebola, that there is a new enemy in the community? And everybody was starting to hear and know that Ebola is here, is killing people, and the School of the Deaf was a place where everybody was. And that experience to me was a very lasting experience. And the solutions were with the people. The school, the teachers, and they were able to communicate far better than we could as, the international expert communities that had come to help. So the issue, I think, around language, names, I don't know what you called COVID here, but I know COVID in Zimbabwe had quite a funny name. But anyway, we're trying to communicate. The second part, which I also now is a question, I want to know how you're handling this. There is a discussion, I think, at the international level with our partners around issues of discrimination in the area of disabilities. And we have had a meeting in Zimbabwe with different organizations that are working in this area. And they were very, very clear that you want to change the nomenclature, the way people living with disabilities, from disabled people, not calling the deaf, call them hearing impaired, trying to change a number of things. The blind are being, we want to call them something else. But the message that came out in that meeting was that, please, if I'm deaf, I'm deaf. Don't call me anything else. If I'm blind, I'm blind. Don't try and change that. What they were asking for is just a voice and a space to be heard, but not for us to worry about trying to spruce things to make a better image, to make it more presentable. I don't know what is your experience in this area. Should this discussion continue? Should we be working around changing the way we refer to these different groups? Because I think it is very, very critical.
Thank you very much, Professor. I'll allow Dr. Kimani to respond to this question, and we'll see if time permits, then we might take some more. Thank you.
Thank you so much for the contributions. Thank you from the Minister of Health for that recap. That's very important, and I'm happy about that. The only challenge towards that is we deal with Chavita. And I have worked with Chavita for the past 7 years. I have been training them. I have worked with them on strategic, developing the strategies, 5-year strategy that is being implemented. I was part of that. So I know one of the challenge they have, as you rightly mentioned, is resources. Both human resources and other types of resources. The type of resource they always get or receive are kind of meager. You know what I mean? It's and I'm sorry about this. Is when we write documents, we write projects today. like we have been doing for the past 20 or so years, you drop in gender mainstreaming, and then you have the project. So people are throwing in disability in requesting for funds and grants. And then after receiving the funds, if they want to work with Chavita, if it is $1 billion fund, Chavita gets 50,000. And then looking at that 50,000, it just ends in supporting the household, you know, the office, the salaries. They can't do anything. So Chavita itself, apart from having so many offices around Tanzania, they do not have the access to all the information, and they do not have access to meeting everybody because of resources. So when we train Chavita, that's very good, but it is kind of one-to-one, because they cannot take that knowledge so much beyond the top level, the leaders of Chavita around. They do not reach the grassroots. That was a quick one for that. On the phrasing, Doctor, on the phrasing of inclusive exclusion, yeah, this has brought me a lot of thinking. And of course, I wanted you to read it with rethinking. And why I say that, today, the people with the disabilities are very well covered, as I said, in the documents. So if they want to raise a hand, A, we have this and that, and we have seen that even here somehow. So the answer coming out is, you know, we have a guideline, we have an act, we have a framework which recognizes the people with disabilities. We make sure that in our service provision centers, the hospitals, we have, you know, recognition that these people should be, you know, the people with disabilities should be taken into consideration. Then now go to those areas. I have asked all of us here, we have been in those areas. When did you see sign language, for instance? Not only having interpreters, but at least even written. I had some pictures on my presentation to present some best practices. I don't know if that could be where we went and saw, at least at some schools, at some where they have sign language, and some of the centers in Arusha and Mwanza where UNICEF worked under this project, where they have sign languages, including information about COVID-19. So inclusive exclusion means they are included on a soft skill, on a soft case in documents, but they are excluded in practice. The bad part of that is they do not, they are always shut down, because every time you raise up your hand, they say, this is in the documents. We are working on it, and we recognize. All right? So these are some of the pictures I was talking about. Of course, these are pictures from the group discussions and that, but there is another picture which presents this one with some, at some schools, you see the signs and all that. This is something I'm trying to talk about, and it's not very expensive. It's just printing some of these materials and educating, you know, some people on some basics so that they can communicate. So I think the last one is the discrimination and the naming, the nomenclature, as Professor asked. So we have been grappling with the same issue in Tanzania, in Swahili first and then English. In Swahili, the general agreement is the deaf want to be called deaf, Kiziwi, right? They don't like to be called hearing impaired. They say if you say that, it means these people are pig-headed, you know, like they are incorrigible, they are, you know what I mean. So they don't like that kind of, you know, labeling. For the people with visual impairment, because, you know, we have these national level communities for people with disabilities differently. We have Shivyawata for the people, we have Chavita and many others, all right? So they also didn't like to be called Vipof, because the connotation of that in Swahili, It can be anybody. It does not respond to visual impairment. It just it corresponds to somebody who does not give, who does not care. You might be seeing everything, you are not visually impaired, but they call you kipofu because you don't see the reality. So they didn't like that kind of naming, and therefore we call them. So this is an area of complex contestation, and it is an area of continuous discussion. However, for me, what is most important is equity. Equity is very important. And not just equality, you know what I mean? Not just equality. Going beyond equality to equity. Naming or whatever is just for psychological makeup, right? But when we talk of services, we are talking of something that has, as a physical impact on this particular person. Thank you.
Thank you very much, Dr. Idigus Kimaya. Please put your hands together for Doctor. Let me leave the floor to the MC. Thank you.
Thank you so much. And to our very own Awet, let's put our hands together for her. Can you please stand up? Yeah, both of you, just move closer and take a very nice picture. As I said, we are going to share these pictures, so momentarily I will share the QR code, or probably the one that is behind our tags for that purpose. We're going to go for a tea break, but I would like to take you through the day before we go for tea break, so at least we know what is ahead of us. So as soon as we come back for tea, which will take 30 minutes, we're going to two presentations, one by Dr. Hussein. Is Dr. Hussein with us? Yes, I'm told is, yes, Dr. Hussein. Dr. Hussein from MUHAS, who is going to look onto positioning key partnerships to drive effective knowledge management systems. And then we're going to have Dr. Godfrey Achaye, looking onto the roles of social and behavior change in community-based disease surveillance. After that, we're going to Q&A. Then we're going to another set of two. One is by James Kengia. James, thank you so much. James is going to talk to us on the nimble monitoring and evaluation systems and accountability. Also, Awet, I hope it's not a tip of the iceberg today, will be talking to us on building institutional capacities, very important. The role of action-oriented capacity gap assessment. Action-oriented capacity gap assessment. And after that, we're going to go on to Q&A. Then we're going to have our brother who's just arrived today from, again, the headquarters. This is your station, I believe. Looking on to now forging into the future. Collective action through social and behavior change in emergencies, puzzle lifting and diagrammatic show. This is very key. And then after this, which is again very important, being at the frontier, you can notice there's some people who have been here for the past 3 days and they have not said a single word. Okay? So I'm going to give everyone an opportunity to give a comment. Okay? If you'll not be comfortable to speak in public, as some of us are, then I will allow you to write on a note. Please, but we would appreciate all of us to just say a word on the symposium. After that, we're going on to the culmination of the symposium and the closure. Then we go for lunch. After lunch, it's meet and greet, mingle, networking, exchange cards. That final selfie and goodbye will happen after lunch. So after lunch, we're going to go on to that activity and then allow everyone to take their leave as they deem fit. Believing that I've been understood, may I wish you a very happy lunch. See you all in 30 minutes. A very happy brunch. See you all after 30 minutes. Thank you so much. DJ? We have 30 minutes and one has already been consumed, 29. Truly appreciating the great work that you're doing. So I am going to bring our next speaker, who is none other but Dr. Hussein. Dr. Hussein, are you here? Please come to the podium. Dr. Hussein Muhammad is from MUHAS. A round of applause as he comes to the stage, please. And despite the fact that we're just from a very nice prevention, and he works as a technical person for the Ministry of Health. Dr. Hussein serves as a researcher and a consultant and provides technical expertise to the government. He was nominated this year to team up with Tanzania delegates to attend UN Conference on Climate Change, COP28, like other COPs in previous years. Can we at least applaud him? He's waving Tanzania's flag, so totally honored. Part of the national team during the disease outbreaks and other parts of his office, disaster management, supporting infection prevention and control, and RCCE. He played a pivotal role during the COVID-19 by ensuring provision of preventive education on various media, TV, Africa, Turkey, Jordan, India, United Arab Emirates, and Madagascar. Surprisingly, this is going to be his first time to present in Tanzania.
Still learning a little bit before I proceed. Sure, thanks. Okay, good morning once again. So, I'm here this morning to present on abbreviated as KM, plays a vital role in overseeing and effectively utilizing existing knowledge. Access to evidence-based information from reliable sources is very important. Really applying knowledge from previous experiences of decision-making transpired previously in order to make it. We will benefit from what we call informed decision making and a better outcome for public health emergencies. And then the other thing which is more important is promoting collaboration among partners. So we are networking, we are sharing experiences, we are learning the weaknesses and the strengths. So that means if you have a certain weakness in terms of capacity, for example, if you learn maybe a certain partner has a certain strength, definitely by utilizing that collaboration, you're gonna strengthen your weakness and be more impactful. But knowledge management also is important for knowledge seekers. As I mentioned earlier, knowledge seekers are always there. Today I'm presenting here, but wherever somebody is presenting, I am a knowledge seeker because it's not possible that I know each and everything. So knowledge sharing, knowledge seeking is always a day-to-day life. So the other thing, maybe how do we bridge the gap? How do we partner for knowledge management issues? So there are several strategies. One of the strategies is having or conducting scientific symposium or scientific conferences, as we are doing here today. So it's important that we plan and conduct a regular symposium to share experiences, and we bring about different experts, researchers, practitioners, implementers in order to share best practices. But we can have other things like expert speaker series. In this case, we might establish some systems or platform where we invite expert speakers to share their experiences, to share knowledge, to share research findings to the audience. So we can do this in so many platforms, like online platforms, for example, or physical platforms, etc., etc. The other strategy is through research and dissemination. You have seen our colleague from the University of Dar es Salaam, who partnered with UNICEF and conducted a very comprehensive research on disabilities. So we can conduct a lot of research. We can partner and make sure we disseminate the findings. It's important that we consider the policymakers, because much as we are generating a lot of information, they might not be very effective because we are not the decision makers. So we have to make sure we also disseminate our findings, disseminate research for decision making processes. But the other thing is capacity building. Mr. Peter has raised a very crucial issue this morning, that much as a lot of happening with regards to knowledge management, but people might not be aware that whatever they are doing is really knowledge management. So we have to strengthen the system. We have to capacitate the implementers to make sure that at least they disseminate the findings and they share knowledge to partners and other stakeholders. So what do we expect out of the partnering in knowledge sharing? One of the expected outcomes is enhanced public health outcomes, strengthened humanitarian interventions. As you are aware, we have a lot of emergencies that might happen anytime. Taking an example of Marburg, what happened in Kagera last time. So it was a collaborative intervention where different partners met together to address issue holistically. But as I mentioned earlier, there is another benefit, which is increased collaboration as well as institutional growth. There is a say, I don't know its meaning. A light bulb in the socket is worth 2 in the pocket. Thank you so much.
Okay, a round of applause once again to Doctor. Thank you very much for your presentation. Wonderful presentation. And I was contemplating as you are presenting, in and out of course, on the topic rather, and in relation to your presentation, positioning key partnerships. And you rightly knocked it out, especially with the final quotation that you said you did not know what it means. And you've reminded me to one of my mom's very own. She likes to use it all the time. 1 bird at hand is better than 1,000 on the tree. So that 1 bulb that is in your pocket is what you have. Okay? But again, your quotation says 2. Okay? When you speak about partnerships, and I believe you'll all agree with me, it's 1 and the other and more. So you'd rather have 2 bulbs in the pocket, on the socket, because you can light them on and off, rather than having multiple ones, probably on the shelves, and one could be broken without your knowledge. So thank you so much, Doctor, for your insights, and keep your questions after the next presentation. We're going to then bring them both on the stage for question and answers. So we're going to look onto the role of social and behavior change in community-based disease surveillance. This is going to be presented by Dr. Godfrey Achaye, and it will be anchored by Ms. Awet. Awet, a round of applause as they come to the stage. Let's clap, 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 clap. Thank you so much. Now, Dr. Hussein, I may have to request you to please come to the stage so that after this presentation, then Awet can take Q&A for both you and Dr. Achai. Karibu sana. Thank you. Awet, over to you. You have 20 minutes.
Good morning once again. Habari za subuhi, still at subuhi I guess, and salam alaikum. It gives me again another honor and a pleasure to welcome Dr. Geoffrey Larry Achai, who is the CEO of his own consultancy firm, but also former UNICEF Chief of Child Survival and Development, who is a medical doctor by profession, but also has a master's degree in public health, and also an expert in disease surveillance, an expert in public health during emergencies, as well as a regular programming. He has worked in many countries, among them Zimbabwe, Eritrea, Solomon Islands, which is his most recent deployment. He currently comes here as an expert lead in terms of connecting how community-based disease surveillance system can also link with social and behavior change, and how can this be leveraged to ensure that some of the key issues around SBCiE are also integrated in the way we program, plan, and also execute our work. Please put your hands together for Dr. Larry Achai to come to the stage and present. Thank you so much.
It's on. Okay, it's actually afternoon. It's a very good afternoon to all of you, ladies and gentlemen. Yes, good afternoon, everybody, ladies and gentlemen. I'm so excited to be here today to see such a very active audience. And also thank you to UNICEF for allowing me to come and present. My topic today is on community-based disease surveillance and the significance of CBS. Yeah. The role of social behavior change in community-based disease surveillance, how the two are linked. What inspired me to take this topic, it was actually my dissertation topic for my master's in public health. What inspired me was a very moving experience that we had in the year 2000 in Uganda. The first Ebola outbreak occurred in northern Uganda, which is my home district. And at that time, there was a huge population of people displaced in camps, crowded, very poor living conditions, and That was because of the war. So there was an Ebola outbreak that was actually not detected in time. So by the time it was detected, it had already spread and killed some people. And it happened that I went to my home village and bumped into it. And with that knowledge of public health, interviewed members of the community on a small piece of paper, and that was the beginning of the recognition. It was 3 weeks after the first retrospective case. It could have been longer. So you can see that there was a lot of delay. And this inspired me, while I was already doing my public health, to choose this topic on community-based disease surveillance, which by definition, if you can move to the next slide. I'll wait, you have the, sorry, is it that? Okay, yeah, that's it. Community-based disease surveillance used to be called rumors in our days of public health, which I thought was not appropriate, and I'm glad that the name was changed later on. It is, to me, early warning and early response. It's a mechanism for early warning, early response, as we shall see. So WHO later on revised the definition, which now stands as an active process of community participation in detecting, reporting, responding to, and monitoring health events in the community. This is now the definition of community-based disease surveillance. It's no longer rumors. Next slide. So I'll go straight to social and behavior change and try and link it, because if you will see later on, community-based disease surveillance, actually it is a community response to an abnormal event. It is a behavior. And a behavior is influenced by social and behavior change programming. And that's where I found the link later on to be very strong. And that's why I'm here to advocate. So I do recognize that there's no single intervention, no single program throughout my work with UNICEF that cannot do effectively without SBCiE. Every program needs social behavior change. And that is a fact which I still urge all my colleagues in all other programs to make sure that SBCiE is part and parcel of their programming. You will notice that during emergencies, social behavior change needs to happen very quickly. You cannot wait. As I was mentioning the day before, you do not start preparing for emergencies when it is already happening. Then you'll be late and you'll delay the response. So it has to be quick. The social behavior change during emergency has to be even much quicker than any other program. So that's important point. Next slide. Community-based disease surveillance detects diseases, and you will see the second bullet saying that a well-designed social behavior change in emergency, which is now what we are addressing, contributes to 3 critical elements of emergency response. The early warning, I think this we shall see in the cases that then also the early response, and then building resilience in community for any future emergencies or shocks. These 3 are critical. It's not enough just to give early warning. there is a need also to have an early response which follows immediately. And then more importantly, as we have been talking these past 2 days, the resilience building, you need to have a mechanism that revolves. It does not stagnate. When the emergency is over, your SBC has to still keep on moving. Surveillance, by the way, is like the radar in an airport. It doesn't stop. It keeps revolving whether a plane is coming. If it stops, then when the plane comes, it will not. So the same thing with surveillance. You cannot stop doing surveillance. Otherwise, you'll be caught with your pants down. You said it, not me. So the three elements are critical: early warning, early response, and then building resilience. Those three have to be together. We will see that. Next slide. So in early warning, what do we mean? Communities need to be alert and immediately report any strange illness, any abnormal event, anything, quickly to the next level. Yeah? The early response is not even enough to say early. It has to be early and appropriate. Because if you do an early response but it's wrong, still we are losing time. So it has to be quick and appropriate. And then thirdly, the building of resilience in communities, as we talked about, is to have that system that revolves like the radar in an airport. It doesn't stop, it keeps going. These three are critical. And if you see these three, SBC is critical for each of them. For the early warning, communities need to be aware of what are these abnormal things. A funny disease or funny death or anything else, they need to know that something is wrong. Early warning, they also need to know what to do. If something goes wrong, you don't just start debating among yourselves. You should know exactly that if I see this, I will go here. I'll go to this next level quickly, without delay. So those are critical, and SBC, change of behavior, has an influence there. And then, of course, the resilience bit. Next. I've got 3 case studies very briefly. Do I still have time? When I see you standing up, I get scared.
I can't connect what you're saying and the slides. This, I think now is on this slide.
Yeah. Yeah.
If you can go back, go back.
No, I thought no, we.
That's a conclusion.
No? Where are you? That's why I brought mine here. It's a backup. Case study 1, just go there. There are 3 case studies.
That's number 3. So
No.
twice back. That's number 2.
Yeah.
That's 1.
Yeah. It's case study 1. This is the one that actually inspired me. This was in the year 2000 in my home district. This Ebola that I talked about came and was unnoticed for 3 whole weeks. There were 393 cases and 203 deaths that occurred in these few months that it was there. The outbreak was stamped out within 3 months, 4 months, which by normal standards, it's relatively good compared to the circumstances that it was detected late, and also there was an IDP camp. An IDP camp is a very, very, very crowded environment in northern Uganda. Every house is next to the other. So you can imagine with that kind of crowding, poor living conditions, and Ebola, it would have been really a disaster. So the lessons we learned there were three. One is that a weak or absent community-based disease surveillance system delayed the detection. It took 3 weeks. Nobody knew what was going on. And then also delayed and inappropriate action resulted in deaths. The point is that the early action must be appropriate. You will come to learn that people fell sick, but they were going to the wrong places. A lot of them went to traditional healers who became sick and also died. That was wrong action. So it was quick maybe, but wrong. Therefore, we emphasize early and appropriate action taken. And then what saved the situation from being very bad in terms of mortality compared to the living circumstances is that there was a very strong political commitment. The district authorities were on top of things, alert all the time. They didn't sleep. The same also for the health workers. Actually, every doctor and nurse in the district declared that they were not going on leave. They were going to work day and night to make sure they stamp out this epidemic. Communities were equally committed. Any sense of a suspected case anywhere, they would actually kind of quarantine, call the health people, the ambulance would come pick them and take them to appropriate treatment center. And that's how this thing was clamped down in 4 months, which I think, as I said, was relatively quick compared to the late diagnosis and the crowding. Next. The next case is also referring to community-based disease surveillance. In a way, this is now in Eritrea in 2020 with the COVID-19. Eritrea was not affected for a while with the COVID-19. Most of the COVID-19 cases were imported. We were talking about cross-border yesterday. So around Eritrea, all the other countries had very many cases already of COVID-19. And there was a lot of movement, porous, we talked about porous borders, across the border. People who feared to die in Sudan, for example, decided to walk across the border and come back to Eritrea. But because of a good surveillance system, community-based, members of communities were quickly picking up these cases and sending them to the appropriate site, the quarantine sites. And then they were managed by the health system. So almost 100% of all the cases that trickled through were picked up by the system. They were quarantined and appropriately managed. Therefore, we didn't have that bad incident of important cases to Eritrea. So there was a very strong community-based surveillance system over there. The government also had a very strong risk communication community engagement team led by Awet, who is sitting here, formed a very strong SBCiE team well in advance of COVID. We didn't know COVID was coming. It was for measles, rubella vaccination. And then built up a team of about 50 officials, government-owned, ready for action. So when COVID came, they just jumped into action and spot on, rapid, a very effective SBCiE team that came into play. Then thirdly also, the COVID response in Eritrea was very successful. The lessons we learned was that the emergency preparedness and resilience was characterized by a very strong political commitment. The government owned everything, and the government was self-reliant. They didn't even want help from donors. said, yeah, we can help us, but we are doing it ourselves. We can call you in when a very strong team. The RCCE team also, as I said, was already in place. So the response was also early and appropriate. Anyone who crossed the border from wherever was quickly picked up and quarantined and then managed. So there was very little importation of any case to Eritrea. And then, of course, they were also using appropriate TV, radio, SMS. There was the call center, there was the SMS. Not very advanced intelligence, but very effective. What you call appropriate technology. Very, very effective. So this was Eritrea. The third one was now in Solomon Islands, 2022. Efforts at the RCCE and risk communication was a bit weak here. There was no good team there. So we had 2 waves of COVID. The first one, of course, came and did a lot of havoc. The second one came undetected for a while, also because the community-based system was not in action. It was picked up by accident at a health facility and had already spread. Luckily enough, vaccination coverage within the city was high, so there was shielding. We did not get any serious outcome. Yeah, I'm almost finishing. So this was it. So for Eritrea, for Solomon Island, the lesson was disease surveillance at health facilities alone is not enough if you don't have a community component, because you miss out. You detect late. Yeah, the early warning was lost. And then also the RCCE response was also not very strong, so it also didn't. So the main takeaways are 3, just to recap. When dealing with disease outbreaks and other adverse health events, are you on the next slide? It is important to remember that community-based disease surveillance, it is not rumors. It is an important early warning mechanism that should trigger immediate follow-up and further investigation. So as I said before, it's not enough just to warn. You should also act quickly. So this early warning should trigger early action. If you hear the so-called rumors and then you sit back and say you're waiting, you're wasting time. So early warning, early response, yeah? And then the response has to be appropriate. You don't take to a traditional healer if it is something else. You take to right. So all this needs the community members to know signs and symptoms and what to do during emergency. And then, of course, the resilience building, we talked about it, have the surveillance system revolving. It should not stand there. It should keep on like a rudder of a plane. So to conclude, this is from WHO Afro. I don't remember the year, but it must be recent. The African region has had to deal with outbreaks of cholera, meningitis, typhoid, influenza, among others, in the last decade, and lately Ebola virus disease. It is known that the countries with weak surveillance systems are not able to promptly detect and respond in a timely fashion to public health threats. So there is need to strengthen disease surveillance at all levels, especially at the community level. This is a statement from WHO Afro, and it is a recent statement. These are lessons learned from the past. So I think that brings us to the end. Asanteni sana. Thank you all.
Thank you very much, Dr. Geoffrey Larry Achaye. So now we are opening the floor for any comments, questions, and any suggestions to take forward for both doctors on the floor. Karibuni. All right, 1, 2, 3, and 4, 5. Okay, we'll start here.
My question is that just to benefit from your insights, how do we balance between acting promptly and at the same time considering communities' voices in terms of the emergency preparedness plans that are being developed? Because to my understanding is that while it's very beneficial to act promptly, but at the same time, failing to consider community's voice in relation to the emergency that we are responding, this may contribute towards the failure of some of the emergency preparedness plans that we are developing. So how can we create a balance between the two? And to Dr. Mohammed, I also have, sorry, Hussein, I also have a question for you. By the way, thank you very much. That was a very good presentation. So we have been suffering from fragmented systems in terms of partnership, more or less contributed by an interest to attribute changes towards what we have been doing. And this has made us to lag behind for a very long time. So my question is that, how do we ensure effective partnership in relation to the social behavior change communication, making sure that there's a system of learning the best practices from different partners, so that it's not a competition, but it's a way of learning from one another. And at the same time, we are able to align whatever we do in relation to what we have learned, like lessons learned from different programs that have been implemented. As you can see that we have different partners and everybody has a way of implementing social behavior change communication. So I just want to take your, to get your take on this. Thank you very much.
Thank you. Thank you so much. Let's please keep our questions very short and brief. Professor, please. Yes, please.
Thank you. Thank you. I think I have a kind of recommendation, and thank you for the presentation. They were good presentation, and my observation or recommendation goes to issues on knowledge management. If you look at the knowledge seeking, the issue of knowledge seeking, knowledge sharing in our country, I think it's still in its infant stage. To what extent the government, the implementing partners, and the other key stakeholders are actually seeking knowledge from where it is being generated, either at the research institutions or at the academic institutions. I think it's high time now we needed to include it in our plans, especially the government. We needed to have dialogue between policymakers, between practitioners, between implementers and researchers on what knowledge do we have which can inform decision-making process, either at the government level or at any other organization which implement different interventions. So I think it's high time we needed to include it in our plan. So that is my recommendation. But to the second presentation, I just wanted to ask you a question. I'm not sure whether the presenter has given a thought of the feasibility of some of the recommendations. If we are suggesting that perhaps we needed to have surveillance system at the community level, for instance, how feasible is it? Is it really possible? Is it practical to have surveillance systems at the community level? I understand that at least the government has a system in place, at least, that if there is any emergency, there are officers from the district level who can go there immediately and start tackling the issue. But then going to the community level, I'm not sure whether that is feasible, but I think he can comment on that. Thank you.
Thank you, Professor. Peter, please.
Thank you, Madam Aweti, and thank you to Dr. Geoffrey for his presentation. One is some sort of a recommendation, taking an experience of Ebola threat in Tanzania, in addition to what to the mentioned the channel of communication, the radio, TV technology. At some point, we also used the other digital platform like the transit television. Transit television are those TV on public buses. We have some on ships and the other on train. So we brought messages, video. We had in collaboration with the UNICEF, we had the story of Ebola, but with the other video clip, and it was very effective because we worked in collaboration with the RATRA, but also TABOA, organization of buses owners in Tanzania, and the traffic police, you see. So just to make sure that those messages were played. So I think that one is, it is free, the initial cost of production, but the dissemination, there is no recurrent cost in terms of dissemination. And the last one is a question. I wonder if we can use even the social media platform in addition to other channels, like to track what is being said, because so many people are nowadays spending most of their time on these gadgets. So I was wondering if they can also be like a social listening mechanism. We have some tools like the talk walker and the like. Can they also serve our purpose that whatever is being said on social media can be tracked and, of course, worked on to just to make sure if it will be like, is it correct or false, things like that one, in addition to what is being at the CHW or at the community level. Thank you.
Thank you very much, Peter. Magara, over to you.
Thank you very much for all. I have some question from Dr. Hussein, especially for benefit for knowledge and sharing experience. We have some challenge in providing the knowledge, especially in the community. We have provided a lot of knowledge, especially, for example, now Zanzibar, we have a rain season. A lot of houses, they get some challenge to get for rain. But we provide some intervention and health education to ensure that the community follow all instruction, especially in health instruction, to use water guard and other intervention. But still, they provide to them health education, but still not follow all health guidelines. So, as a senior lecturer, senior public health specialist, can you assist us at least how other technique or a strategy to use for community to ensure that they have received and to understand what is our health intervention to achieve our targets. Thank you.
Thank you, Dr. Magrao. The last two questions, and then we'll go to respond, please.
Thank you so much. My name is Alfonsina Kagaigai. My question goes to Dr. Hussein, who presented about knowledge sharing. So I think from the day one, we have heard of the importance of community involvement. And most of the research, when we do, the dissemination will be done in the big symposium or conferences. But I think majority of the researches that we do them at the community level. So do we have any mechanism that we can share the knowledge with the people that we do research? At least, I don't know how we can do this, but I think there's a need of thinking how we can also share the knowledge that we get from the people who give us information that we then analyze and get the information of what we are looking for with them that who provided the information. Thank you.
Thank you so much. That's a very important question. Okay.
Thank you for your presentation. Mine, I think, is always an afterthought. How often do we always tap on our own wells? How often do we always drink water from our own wells? That is concerned with the knowledge sharing to Dr. Hussein. So my question is, what is the role of African indigenous knowledge system in advancing social and behavioral change in emergencies? We know we have various systems within our context that actually can help out. Do we always bring traditional healers along with us? Do we use storytelling to bring up, to send information around? Do we use songs, folklore, and others? And also maybe when we talk about witchcraft, is something that maybe some of us may not want to talk about, but perhaps if you look at it positively, it could be something that can help us to understand people more, and maybe if you could share knowledge among ourselves as Africans and see ways, better ways that perhaps even witchcraft can be used to advance social and behavioral change. Thank you.
Thank you very much. I think that's a very, very important question, Dr. Hussein, indigenous knowledge. Yes, just one last, I saw a hand over there and I said I'd pick it, so please, and then we'll just take the answers. Thank you.
Thank you. Going to contribute or ask questions from the sessions of knowledge management. I'm going to talk as partner from local government authorities, as my colleagues there said that as local government authorities, we participate in collecting data and all the information and the knowledges that you get, you enlighten us, are coming from local authorities. But unfortunately, we don't get feedback or benefit from what you have been doing or collecting the data. So I'm wondering how maybe this symposium or for these gatherings, they can see how well or how best they can bring the feedback they get from the community and implement those feedbacks as how they have maybe learned. But the other thing also, even though you are saying that if you don't have data, you have no right to talk, but I'm going to talk according to my experience as maybe during Ebola crisis and COVID-19, the institutions we had a very difficult time to deal with the institutions, especially they have knowledge, but practice gap is very big, and they don't. I don't that they don't, or they are not good in practicing what they have in their knowledge. So maybe the SBCiE, I see, should maybe look on how best we can communicate with these high learning institutions. Most of the time, they develop materials for school children, but they overlook the high learning institutions, and they are ones who are, we are expecting to get much from them, but we don't get anything from them, especially on the practices of what they have been learning. Thank you.
Thank you very much. I'm giving the floor first to Professor Hussein, and then we'll move to Dr. Larry Achai. Thank you. You are.
Yeah, thank you. If you find people, sorry, I don't know this way. Is it working? It's on, but yeah, it's on, but it's not. So thank you so much, participants, for the insights, for the questions, for the recommendations. So it seems knowledge management issue is a hot cake, and for us it's a golden opportunity, really. And should I start with yeah, the extent of yeah, there was a question by one of the partners that how do we link together, how do we strengthen our partnership in terms of sharing knowledge? Let me say that we are all knowledge seekers at one time. If you want to improve our institutions, we have to learn. Once you meet someone new, once you meet somewhere in a meeting, or once you have time to speak, you will always learn something new. So it's very critical, much as we are all focusing on social behavior change in emergencies. We shouldn't work in silos. We should find a way, platforms to share whatever we're getting out of our interventions. This is really very critical and very important. And that's why the School of Public Health, MUHAS, and UNICEF and other partners has organized this symposium so we can learn. We can see the importance of partnering. We can see the importance of meeting together and sharing and learning. So out of this, I think we might come up with one of the important recommendations and a way forward on how do we strengthen such kind of gatherings for future use, so we can always make sure we strengthen our collaboration, we strengthen the way we share knowledge, we learn from each other. This is, I think, very important. Professor Gasto, he recommended to make sure we strengthen the institutions in knowledge management issues. But let me say that we also have to position ourselves. For example, we are academic institutions. We are researchers. We have a vast knowledge. We have a lot of capacities in all fields. But if we do not market ourselves, if we do not make ourselves visible, partners might not be able to utilize our capacity that we have. So much as we are inviting you partners to partner with academics, I told you yesterday that academicians are everywhere, but it's important also for us as well to market ourselves, to make available, to make visible to you. So we have to find also ways how do we make sure that you understand our capacities, you understand our potentials, and how do you reach us? So this was just to strengthen what Professor Gasto, my boss, has just mentioned. There is another issue on knowledge sharing to communities where we're getting the information. Actually, it's very unfortunate, and I can say it's quite unethical to some extent that you go, you ask questions, you collect data, you come up with very, very good information, and then you don't provide the feedback to people who gave you data. I think that's not acceptable, except that we are doing as a routine that, you know, I have ethical clearance, I will just go and collect the data. But more important is the fact that they also need to get feedback. So the experience from our field activities with the students, for example, if I can say it one example, if you go to the field work, say you are visiting a certain village or a certain district, once you have collected data, information, the students have to do some analysis before they depart. Then they have to make sure at least they summarize their key findings, and they hand over to the village leaders or the ward leaders or whoever is there, just to make sure that actually they get feedback from the findings, instead of just going with all the information without them to benefit.
Professor Hussein, you have less than a minute to conclude. Thank you.
Maybe let's say a little bit about indigenous knowledge. I think I'm not really an expert on indigenous issues, but what I can say, I think there are good things out there. Traditional healers, alternative medicine, I think they are part of the communities. They are part of service providers. So what is more important actually is just to sit with them and make sure that they align with some precautions, because, like, for example, if they are providing medicines to people, we cannot deny that people will always go to traditional healer. There is no way we can deny that. But I think what is more important is just to work closely with them and make sure that whatever they are providing to our people is not toxic and it's not going against the laws of the land. Partnering with LGA, I've already said, and yeah, I think maybe, I don't know if I've addressed all the questions, but because of time, I think let me end here. Thank you.
Thank you very much, Professor Hussein. Let me give the floor to Dr. Larry Achai. Thank you.
Okay, the few queries, I think, let me clarify. First of all, when we talk about community-based surveillance, it is a very much simplified format that we use. The main purpose is actually early warning or alert. And then remember, I talked of the next level. The communities are everywhere all the time. The health workers are not everywhere all the time. They come and go mostly. So if you want a surveillance system that rotates like the radar of a plane without stopping, you need something that is constantly present and constantly observing things. So that's why we start from low down, from the household community level, because usually they are the first to see anything. What they see is actually an alert. It's not confirmed. Nobody will confirm that this is malaria or Ebola or typhoid. They only raised the alert. We saw something unusual. So take over. That's what the system is like. We also do help them with simple case definitions. Say if you have fever, vomiting, and headache, for example, it suggests this, something like that, simple, that they all know, not anything complicated. So that's what they use. Their role is to sense, to alert, and then report to the next level. So I think there is no way the health system can also work without them. As you saw the case in Gulu, we did have a surveillance system of the health system, but it did not detect this because these things were happening at community level. So they are the eyes and the ears of the conventional surveillance system. So it's, again, partnership, as you said. They work in partnership. The early action doesn't mean treatment. Early action actually just means referring to the right place at the right time. That's all. That is action in emergency. So there is going to be no conflict with the health system on that either. The feasibility, I have already talked about it, simplified, interlinked, and also two-way. Because if you have an active surveillance system of the health system, it should also be communicating back to the communities. We have the radios, the talk shows, the call-ins, whatever it is always telling the communities about the illnesses or the actual emergencies. So if they are not sure, they will always get a feedback from the health system. Or if the health system is alerted, it is up to them to go and investigate. So it's a two-way system, it's a partnership. Therefore, it builds into each other. For the traditional healers also, I think, the case of Ebola and Gulu, as I mentioned, they were recipients of Ebola and they didn't know that they were handling Ebola. So they fell sick and died. So did the health workers in the health facilities. Both died. So it means when you are dealing with such epidemics or dangerous diseases, you need to involve also the traditional healers and warn them. You should also know that this one is a hot case. You don't touch. If you see it, you also refer. And indeed, in Gulu, traditional healers are actually referring the patients. Or they would even say, don't come near me, go to the hospital. So I think it's a partnership that needs to be managed. I think that's it. Anything else?
I think there was one question from Peter regarding using multimedia or something to that effect. Peter, if I got it correct?
Social media.
Yes, yes.
That is for
yes,
well,
I think one thing, maybe I can comment
yeah.
on that one, actually. Maybe some of the examples that were coming through were specific to certain contexts, and they were tailored to the needs of the communities, as well as to the needs and the availability of resources and specific digital platforms that were there. So maybe your comment is valid, it's well accepted, but again, it's tailored and targeted. That's why you saw the examples coming through like that. I hope I've answered your question, but we can do this bilaterally. Thank you so much. I think let's put our hands together for the team, and then we can take a group photo. Thank you so much, MC.
Can we put our hands together again for our presenters, as well as a word for that fantastic anchoring of the session? Thank you very much. So we are going to go on to the next series of questions, but looking onto how unhealthy we all look, allow me to blend in a bit of juice and salads and all the healthy stuff through reviving our spirits with one beautiful song. But again, as we do that and as the panel steps down, I think I would need to bilateralize, and I look forward to your presentation, Ken. One of the things that I've really been missing in all the presentations, or probably because I've been moving up and about, are the issues related to financing. I've really been missing that, particularly the fact that I also asked Professor Collins' session yesterday that most of our projects are really, really donor-funded projects. From surveillance, I stand to be corrected, Dr. Professor Chaye, from surveillance to, you know, programmatic, to even look for partners. We want to be financed to look for partners. So does this mean that our governments are not serious really to really commit resources to issues like surveillance, to issues like communication, so that we're really able to take this forward? Then my second issue, which again I look forward to the next presenters, that includes you, Awet, coming up next after my presentation, after the presentation from Behavioural, is most of our communications have been reactive more than proactive. And I think for the past 2 days, we've also been pondering on the same. And I think part of the essence of gathering all of us together is now how can we improve from being proactive in communicating to from being reactive to being more proactive. I think it was also raised in some of the presentations that were made that, you know, we know that we are vulnerable. We know that things ought to happen. But then do we wait until they happen for us to actually take some measures, including communication? There are issues that were raised. I think one of us also brought some issues of washing hands, for instance, social distancing, etc. Now post-COVID, what are some of the lessons we draw that could still keep and ensure us we remain healthy and safe? Okay. Without further ado, I am just provoking minds of you specialists, and I look forward to the forthcoming presentations. The next one will be from James Kengia from Behavioural, who is going to speak about nimble monitoring and evaluation systems for social and behavior change in emergencies accountability, so aspects of accountability. If some of the issues I've asked feature onto that as well, James, I'll appreciate. And thereafter, we'll have Awet, again, looking onto building institutional capacities, which I also believe it has to do a lot with relationship partnerships and financing as well. So I look forward to your presentation. And later on, as we come to the end, we'll have Forging into the Future. James. Can we clap our hands for him, James? James, I was to bring you with a song, but since you decided to get here, please, Karibu. So towards the end, we're going to have the final presentation that's going to look onto forging into the future, collective action through social and behavior change in emergencies, puzzle fitting, and diagrammatic show, which will be given by my brother Ken. So for now, let's all stand up, just stretch up a little bit. The beautiful 3-minute song, I promise it's 3 minutes. And I introduce Ken before I give him the floor. Awet, are you coming to sit at the front? Because after him, it's you. Yeah, and then we take the questions. Can you all please stand up? Professor Wafa, I know you will like the next song and probably you would want to shake a little bit more. It's not the cha-cha song. I'm saving the best for last, but I hope you'll enjoy this one as well. Music is the source of life. Bring it on, DJ. For his, I admire you. I believe when I grow up, I'm just going to be like you. Thank you so much, Professor. So let's get to know more about, a little bit about James, Dr. James from Behavioural. He works with Behavioural. For those of us who do not know what Behavioural stands for, it's President's Office, Regional Administration and Local Governments. We call that in Kiswahili TAMISEMI, as the coordinator for research and publication. Okay? Some of us struggled earlier on with data, information, and research and publication from the President's Office's authority. Excuse me, your mic is on. The gentleman next to you, yeah, that mic is on. Yeah. So he is a coordinator for research and publication. He is an experienced public health specialist with a demonstrated history of working in the hospital and the healthcare industry in general. Dr. Kengia is a principal dental surgeon with also a postgraduate diploma in hospital management that was part of an international leadership training, ILT, in hospital management, which was supported by the government of Germany through, by then, INWENT, Capacity Building International Germany. He holds an MBA as a medical doctor from University of Applied Sciences, Nulm, Germany, and holds a PhD in public health leadership. He's majored in healthcare economics from Tokyo Medical and Dental University in Japan, under the scholarship of the prestigious Japanese government. That word, I can't say it in Japanese. MEXT scholarship as a postgraduate diploma in leadership organized by Uongozi Institute in partnership with Aalto University in Finland. He also has worked as a member of the Regional Referral Hospital Management Team, Regional Health Management Team, Acting Regional Medical Officer for Mwanza Region, and Principal Investigator / Director for Mwanza HIV and AIDS Services Improvement Projects. While working as the regional, RRHMT and RHMT, and for the Behavioural, he has been involved in planning, coordination, supportive supervision, monitoring and evaluation of health services. Currently, he is also involved in teaching health system management course for Masters of Science students in public health at the University of Dodoma here in Tanzania. At the University of Dodoma, he particularly teaches planning, organization, change management, resource management, leadership and management, monitoring and evaluation, and an introduction to health economics. Ladies and gentlemen, this is none other but Dr. James Tumaini Kengia. A round of applause as he comes to give us his presentation. Doctor, you have 20 minutes. The time is 13:10. I've taken 3 minutes to just introduce you. So you've got 17 minutes. Karibu.
Thank you very much, the moderator. So I'm taking the floor just after a very good song. But myself, I was also waiting for the other stuff that goes with that song. So so I'll be taking through the presentation of monitoring and evaluation for SBCiE accountability. And my role is just to give kind of stimulative presentations that will be followed by a couple of some discussion later. So the presentation is organized to 4 areas. A bit of the introduction part. I'll also touch base on some little bit of basic of monitoring and evaluations, and then a bit of why is monitoring and evaluation important, especially as we're discussing SBCiE, and also some key steps for monitoring and evaluations. So just briefly, as the introductory part, we are discussing about SBCiE. Now is the 3rd day. So this one is a very important area that nowadays also coming very strongly, especially as we are developing most of our plans from the national to sub-national levels. we usually also incorporate some SBCC activities. So because of that, as we incorporate some of the activities for SBCC, it becomes of paramount importance to include also something related to monitoring and evaluations in the activity, for the activity related to SBCC. So this is very important because we have some activities embedded within the plans. We need to monitor them, and not only monitor them, but also need to evaluate, in particular with the interest to understand whether we have reached what we intended to have as goals or objective of our interventions. So just brief, I think this one is something that is well known, but for the purpose of stimulating discussions, monitoring is really, we are talking about a routine kind of, or continuous process of tracking some of the progress of particular indicators of the particular interventions, whether it's a program or in a policy. And what is really important here is while we are doing monitoring, it's kind of giving out some of the alerts, or even if there's a trend or something that is increasing or decreasing. So it gives us some alert. And parallel to monitoring, we usually conduct some kind of a systematic or episodic kind of a deep, in-depth assessment in understanding the reason of why, in terms of the success or failures in attainment of some of the intended interventions. So as we are discussing about SBCiE, it is really very important to conduct the monitoring. Monitoring is important, and of course also the evaluations. So monitoring and evaluation focus really is, we have like two areas. Number one is, as we are discussing here, SBCiE, monitoring is very particularly important because of the issue of monitoring the implementation aspects. Usually we have some of the resources as inputs while we are doing the SBCiE interventions, but of course that will go parallel to the implementation of some of the activities. And then later on we have some of the output that is emanated from the activities that have been implemented. So in SBCiE interventions, it's really very, very important and critical as during the public emergency that we really monitor the implementations, not only of indicators that are related to our input, the different resources, but also the output, what is expected out of the implementation of the activities. That's all about implementation monitoring. We are interested to look upon the means and of course the strategies. This is important because sometimes we might be it might be necessary to change some of the strategies as we closely monitoring the implementation of the interventions. But of course, that happens parallel also with result-based monitoring. Result-based monitoring, the interest here is really at the level of the outcome. Outcome-based monitoring, that is being advocated recently by the World Bank. We used to traditionally monitor at the level of the output, but what is really interesting is to monitor the level of the outcomes. Why? Outcome is where the change of behaviors is happening. So what we see from the outcome level, that means the behavior has happened. And then with SBCiE, then at least we need to monitor for result from the level of the outcome. And of course, in longer terms, we can also check upon the impact of the implementations. So generally, in monitoring and evaluations, we use the traditional logic framework as a framework, logical framework for monitoring and evaluations. Down there, from the level of the inputs, looking upon all the different resources, and of course, that will facilitate the processes, the different activities to be conducted. For example, if our interventions is related to some activity related to training people in particular skills to influence the change of their behavior, then we will have to check upon the people trains. And if we have some of the leaflets that need to be distributed as part and parcel of the SBCiE, we need to check at the level of the process. But of course, later on, the level of the output, we're able to come up with some of the indicators that are going to check now in terms of what happens after we have implemented the related activities, including, for example, the people reached with SBCiE leaflets, and other could be the people reached with a particular targeted trainings. And of course, our interest at the level later on is to have the outcome level monitoring, where we have some of the changes of the behaviors, and of course, longer term impact in terms of the disease, mortality, morbidity, prevalence, incidence, etc. So why is it important to conduct monitoring and evaluations? Really, our interest here is to track progress of our activity against indicators. So this is very, very critical. We need to track to know whether we are flaring into the right direction or not. We have some of the indicators, yes, but we need to track whether we are performing well or not. But of course, I already mentioned it, we might need to do some adaptation in terms of the strategy needed against program goals or objective. But of course, for the purpose of accountability, it is very, very critical. We do monitoring, we collect data, we have to share with our stakeholders, the audience, the politicians, for example. We might invest a lot of resources as SBCiE, but if we don't show to our stakeholders, then it becomes a little bit challenging. But monitoring and evaluation, it helps also to convey the message to our partners, to promote accountabilities. Of course, it assesses some of the success in terms of our strategies, communication strategies, but also identify lesson learned and best practices. It was also echoed during the previous presentations, especially later on while we are doing the evaluations. Then we need to share some of the best practices and even the reason of not success in some of the areas, the lesson learned and best practices. But of course, inform future emergency communication response if we have a very good monitoring evaluation system. So as we are discussing now SBCiE in the context of public health emergencies, really we need to reflect or echo into 4 different area steps. Point number 1 is being advocated that it's important really to have this kind of monitoring evaluation system, especially prior to the crisis. This is important. We need to have established preparedness system that can be activated easily during the epidemic phase. This is critical and important. Number 2, to activate simple monitoring evaluation systems during the early phase of the crisis, early monitoring. But of course, a more robust, developed monitoring evaluation plan is important while the crisis we have in stabilizations. But the other thing that is important after everything is ended, to conduct a post-emergency evaluations of our SBCiE interventions. So reflecting the number 1 part, as I said earlier, it's very important to have this one during pre-crisis phase, to have everything that is at least can be activated immediately when we have the crisis. And number 2 is to activate a simple monitoring evaluation system for early monitoring. There you can be able now to collect some of the data, some quantitative data, for example, as I gave some examples from the level of the input, process, and output level indicators. A measuring issue like the percentage of household reached with messages, door-to-door messages, number of leaflets distributed, etc., depend on the level of the indicators, whether it's the input process or the level of the output level. But what is really very important also, sometimes it happens during the public emergencies. We have some of the issues that we also need to do monitoring qualitatively. For example, in Tanzania, we have had a lot of hesitancy during the COVID-19, the issue of vaccinations. The hesitancy issues and likes, the rumors, management, and misunderstanding need to also to be documented, even if it's qualitative, to inform how best can we improve our strategies. And the other thing is during the phase where you have the emergency stabilizers, it's very important to have more rigorous and guided, better defined tools for the monitoring. That means we need to have a very concrete now monitoring evaluation plan with a very clear goal, objectives. We have some very clear verifiable indicators in the plan, but also the means of collection of the data, but also the timelines and who to collect the data and the cost. It must be costed kind of a plan. And that one goes parallel with our communication strategies. You have SBCiE strategy on one side, but of course, how are we going to measure it? You need a very concrete monitoring and evaluation plan. Lastly, but not least, we have to conduct post-emergency evaluations. This is very important to measure. As I said in the basics of evaluations, here we're talking about now to understand and deep dive on the reason of all the success and failures and document it. And most of the cases here, as I refer to COVID-19, after this one, as a coordinator for research and publication at PURAC, we received a lot of this kind of evaluations. It was well funded, and of course, kind of duplication sometimes. Coming from different partners, people want to do.
Asante sana. Monitoring and evaluation remains the backbone. We all agree. But there's also a component of learning. You know, you just don't monitor, you evaluate. But then what you've monitored and what you've evaluated, how do we then cascade that to the next phase that then includes the component of learning? And I hope not me, but somebody from the audience on that time, they will ask some of that. One of other things that comes along monitoring and evaluation is now sharing those lessons, you know, key lessons learned. I believe the session that just ended by Achaye and Hussein should have learned a lot, or could have benefited a lot, but I think they complement each other from the discussions that the surveillance as well as building partnership, etc., to as far as monitoring and evaluation and learning are concerned. Now I will not read Awet's bio. We love her, we know her. Maybe she can tell us a little bit about Simba and Yanga. Do you have any of your favorite team? Which is your favorite football team, if at all you watch football? So who is Awet outside UNICEF? Yeah, that. And then you proceed with your presentation.
Thank you so much, MC. Shape the future agenda of social and behavior change. Professor David Mould unfortunately could not be here, but he is the designer of the C4D, or Communication for Development online and face-to-face course that was rolled out for over 400 people around different country offices in UNICEF. But he's also the lead lecturer in University of Ohio. He's also a Fulbright scholar, and he's engaged on a lot of work that we do around capacity building, Symposium, or even some of the build-up activities that we've been doing to build up to leading to the Symposium, and changing the narratives around the global shifts on SBCiE, on social and behavior change. And then looking at the national development priorities and the way after post-COVID-19 things have changed. How are we now aligning and ensuring that the national development priorities are also addressed through this capacity assessment? Role and positioning of SBCiE, again, as I said, lessons learned from COVID-19 and RCCE. The work we've done in RCCE is tremendous, is a lot, but how do we shape the SBCiE agenda? Empowering SBCiE, again, through capacity building, and at the end of the day, system strengthening. So I'm going to present to you two types of capacity gap assessments that was done here in Tanzania country office. I'm not going to delve deep into that because of time limitations, but there will be documents that will be shared with the team so that they can be channeled to you. There were two capacity gap assessments that was done. One is what we call the CADRI. CADRI is capacity assessment for disaster risk reduction, and the second one is the capacity assessment for social and behavior change. The first is a one-stop shop
that really offers multiple expertise from the agencies that you see. And this was done at the behest of the government of mainland and Zanzibar. So this really encompasses what needs to be included when we talk about disaster risk reduction, where you find risk communication and community engagement to be one pillar of that. So what has happened so far? There's been a lot of activities where Tanzania is also part of. The diagnostics or the capacity diagnostics, planning and DRR, which also in the process builds the capacity of the government system to ensure that this is sustained beyond the initial capacity gap assessment. And then there's also a prioritization exercise that is done after the recommendations are sent. And then country skills development and training, as I said, for sustainability. Also looking at what are the legislative structures, reform institutions, and policy systems that are in place that are supporting the disaster risk reduction or emergency response, and then deploying also specialized expertise in key sectors. So the cadre has been supporting these different countries in a lot of these assessments. I've been part of this mission, and my focus was basically on risk communication and community engagement, and I was leading that part of the assessment. This is the online platform and what it looks like, and the modules that are covered under the cadre assessment. So what are the areas that we've looked at? So I'm just comparing here the cadre and the SBC capacity assessment. So the primary focus of the cadre was to really look at the national, local, and the public sector, and 70% of the focus of that was on the local and public sector. And the secondary focus was the private sector and the civil society. Beyond focus, however, the cadre also looked at citizens and communities, because communities are integral part of our response. They are the leads. They are the ones who immediately identify, as Dr. Achai was mentioning earlier on. Community-based surveillance is really not a myth. It's something that we can implement because they are the ones who first identify this. I think the Kagera Marburg disease outbreak itself has its own story that can tell us how this disease was surveyed. So communities have a critical role. So communities was also targeted. The adaptive absorptive capacity of the ecosystem in terms of financial resources as well. The allocation, not only the allocation, the adaptive and absorptive capacity as well. And then external supporters. Now here the UN system is put as external support in the cadre mission. However, in the capacity assessment for social and behavior change, as I said, cadre had SBCiE as a pillar and it was assessed. In capacity assessment for SBC, the full focus was on social and behavior change. So here we did consider the national and local as well as public sector. We also considered academia because they are our partners. If we're going to advance anything in SBC, we need to embed this and partner with our academic institutions. Media is our key ally. The private sector also, I was talking about uncharted territories earlier, but that's something that we are really delving into from headquarters side. From country office level, how we can look at that, and civil society as well. So as you can see, the green ones were added on to the overall cadre assessment as part of the SBC. So what we used is, again, a whole of society capacity or an approach. I'll quickly go to that. Again, it is integrated approach because it looks at that nexus that we really want, that transition, that smooth transfer of the knowledge, transfer of translation of knowledge, transfer of knowledge, but also transferring of capacities, because we do build a lot during these emergencies. We are there, we are responding, we are training, we are generating data, information and evidence, but how are we doing this in our regular programming? So there are a lot of, there are some principles also that were included, the gender issue, leaving no one behind. We've been talking about this. Mainstreaming of conflict sensitivity as well, even though this is basically on the DR side. Integrating climate change. Climate change has also been one of the main agenda and narratives that are shaping the way we design our programs. And multi-hazard approaches, because we cannot really talk about single hazard. We are really operating in a poly-crisis situation, and we really need to be conscious and focused. So a multidimensional risk would also emanate from the multi-hazard approach. Next slide. So what are the dimensions that we've covered in this? So the one on the left is for the CADRI, the one on the right is for the SBCiE. So we've looked at the governance structure. We've looked at extensive acts, policies, and strategies that are in place. The country has extensive normative tools in place that guide and shape the way we do business in disaster risk reduction. The operational plans are also there. Institutional mandates are very clear. Who does what, roles and responsibilities are also clear. The main issue comes in when you talk about now resources to activate, to implement, to sustain, to scale up. So that's where you see most of the issues coming through. Technical, managerial, and soft skills and competencies are also there. Even when you look at evidence generation, some of the evidence that come through our statistical systems, our administrative data that's generating for various sectors, you will find that a lot of this data does inform and shape the work that we do. However, some of these are outdated, and some of the recommendations that were coming through from the CADRI mission was that they needed to be updated along the lines of the global guidelines and frameworks that were coming along. Again, in terms of coordination itself, it's very, very clear where the DRR system sits, whether it's in the second vice president's office in Zanzibar, whether it's in mainland. We clearly know where it sits and who does what, where, and when. And when you look at the details and even the follow-up action that went through, because this was done late 2022, and the implementation started early on this year. So there are lots of operational plans that are already put in place. Now financing, financial instruments for DRR and CCA in terms of budget, risk transfer, even private financing. A lot of these were also assessed. And there was something that we found out, that there is a budget that actually sits, that is activated when a disaster strikes. And we were informed that that is readily and easily available to be activated. So that was a very important part of the public financing aspect of the work that we do. Data collection, as I said, we do have a lot of data that came through. However, when I cut across and I assess the situation of risk information, the technologies that we've deployed, even though they are operational and they do help us to do the routine work that we do, when it comes, for example, to, our TMA right now is really giving us a very good information about the floods, the impending issues, or the key actions that we need to take and the risks that are involved. However, when we look at the technologies that are also involved in helping us, some of the indigenous knowledge that's coming from Zanzibar is shaping the agenda there in terms of what and how, but the technology actually is really lagging behind from that aspect. So in risk information, even though, yes, the data is collected at times, the way we are cascading it, the way we are communicating it, and the way and the speed with which it should reach communities should be and could be improved. As part of that, there was a lot of community-based assessment also that was done, going into the communities and seeing how the Shia structures or the community-based village structures and so are engaged in this. And this was a very impressive to see that the involvement of the communities was paramount, even though some of the formalization and the structuring itself could have been improved. So there is a lot of investment that was called for and that needed to be done, especially around technology and equipment, and then ensuring that the knowledge transfer itself is also systematized. And so on. So in terms of the SBC aspect, even though the SBC really looks at also based on the findings also of some of the cadre assessment, the SBC built on it and looked and deep dived through the lens of behavioral insights, behavioral sciences, through the lens of the shift that we are bringing to ensure that the systems, not only the Ministry of Health, but also the Ministry of Education, the Ministry of Communication and Information, Ministry of Gender, the Ministry of Water Resource, and the other line ministries that work with us and should have an SBC structure in their ministries are also put on board and look at their institutional implementation structure when it comes to SBC. Now, yesterday I spoke about, if you remember, about the IHR guideline, the International Health Regulation Guideline. The International Health Regulation Guideline really mandates the Ministry of Health to have a system and a structure in place called the Health Promotion Division, where Dr. Peter Mabwe leads it, and this structure has the right capacity systems, the policies, the normative tools, data generation in place, because one, it's mandated. The second, most of the outputs that we have in health are dependent on social and behavior change. So there is no way out with it. When you go to the education sector, you will not find that kind of a system, because I can say that, I cannot put a percentage on a number to it, but we cannot say that this much of the outcome is really dependent on social and behavior, even though out-of-school children, for example, when they are the re-enrollment, the retention, the completion drive is done in the communities, we deploy social and behavior change strategies. When we go in deep dive and understand what are the norms that are driving the communities to marry their children off at the age of 14, at the age of 15, instead of sending them to school, then really you deploy social and behavior change. When you go to the community development section, where you talk about parenting programs and parenting issues, and you're talking about child protection, where the issue of child protection is housed, and the ministry is mandated to run that, then you talk about violence against children. Let's take an example, just a brief example here. You deep dive into some of this violence against children and where they are perpetuated. You deep dive into it, and all you go to is beyond the knowledge, the attitude, and the practice at household level. There are other drivers that we don't know about. And these drivers can only be picked by behavioral insight studies, social science studies, or social norms analysis that we need to do to inform the program. So it's looking at the policy, it's looking at individuals, it's looking at staff competencies, it's looking at how program managers should be leading it and what are the enablers that are helping us. I don't know how many minutes I have, but okay, all right. I shouldn't be asking these questions. So this is the shift that we are currently experiencing in social and behavior change. We are applying a lot of behavioral sciences. We're focusing on system strengthening. This has been covered in the last 3 days. We're looking at even improving the services. Now, people say like, how does SBC have any business doing now talking about, about service improvement at health facility level? But yes, we do, because if the healthcare provider is going to tell tomorrow the caretaker to bring in the child for the MR2 vaccine that the child needs to take, the healthcare provider needs to know how to communicate with the mother or the caregiver and apply interpersonal communication skills. And this comes through the technical expertise of, this is just one example of social and behavior change expert. We also are influencing through our applied behavioral sciences or social sciences, the supportive public policies. We're looking at how we engage with civil society organizations such as Shavita, Shivyawata, to change the legislations or its acts that we need to put together, or shape some of the normative tools that ministries and line ministries are implementing to advance changes in some of the systems that we are implementing. Community engagement, I will not talk about, and then the SBC, we've all been talking about it, so I will not reiterate that. So now we're talking about even the private sector. How does now private sector really fit into social and behavior change? Where the first day, if we recall, we had NMB, CRDB, or even some people from the mining extractive sector, I think, in this meeting. But we see that even within this shift, there are a lot of areas where we converge when it comes to the private sector. I've had a privilege of looking at the theory of change for one of the big banks, and it was impressive to look at how they really want to invest on young people, on adolescents, especially girls, and how they would want to empower, which is one of the part of SBC, to ensure that they advance their organization goals. Yes, they are profit-driven, some of the private sector, but when you look at the long-term and the short-term goals, it includes that, it ensures that they are also looking at or deploying some of the social and behavior change strategies that we are applying. So I will not, I think, say much after this. Maybe I'll leave the floor also to Ken, since he's going to come here to do the closing later on. I'll leave the floor for any comments or any questions that could come from the plenary. Thank you so much.
You know, after Awet has done so much justice to this symposium, she deserves a big up, warm round of applause. Let's give her that. Yes. Excellent. We'll not reiterate to what presentation she's made. Let me just go straight into Q&A. Interest of time, I will take two hands. Hand one and hand two. Four hands, thank you. Starting with the lady at the back, then Professor Collins, and the lady here, and the lady there. So thank you, Professor Collins. You're representing all the men in the house, because we only have 3 ladies asking question and you. So please, let's proceed.
Thank you very much.
Keep it short.
Yeah, so my question goes to Dr. Kengia. Thank you very much for a very good presentation. So learning from the emerging diseases, whereby we see that it's not only the health sector that is capable of addressing the emerging issues in public health. So how can we ensure that the M&E plans that we develop also captures the contribution of other sectors, especially in relation to social behavior change? Thank you.
Good one. Prof, would you like to go next?
Yeah, thank you, and thank you, Ms. Howard, for your presentation. The discussion around system strengthening, which you talked about yesterday and also today, is actually quite thorough. And I just want to encourage you and the UNICEF leaders of 2 points. We concluded a 2-year UNICEF think tank on social and behavior change that I was a part of. The last report was last year, December. It would be helpful if one take a look at those recommendations. I'm not sure how widely they be circulated, because they do amplify a number of the points you raise, and chief among which is looking at capacity at different level. But what a slight different might be that the capacity and capability is also something we need to check at the institutional level. So it's not only at the community level. An example would be Professor Munodawa first comment about academic and work at UN level. We try to come up with language that we think is more equitable. But when you go into the community will say, that may be your language, that is not ours. That is practice-based evidence. Is when the deaf said, I want to be called the deaf, not hearing impaired. We see this in the US in different experiences we've had where we come up with this language. So there's capacity in the community, and there is a need to also assess what goes on at the institutional level. I think I've made this point repeatedly. If I'm in Brazil, I can make reference to Paulo Freire, and it resonates with everyone. If I'm in India, I make reference to Madame Poulet's work with reference to Teresa being elevated and Poulet's work not being talked about. I'm in Tanzania. I really would like to see more of Mwalimu Nyerere's fingerprint on the work that is done to elevate why it's so important to recognize the importance of collective engagement. The communitarian notion is so central to the work that we have to do, especially when we want to ground it. And it's represented in the 564th Street and Chairman, as I mentioned yesterday. So if we can do more of that, I think we can go far with it. Thank you.
Thank you very much, Professor Collins. Over to you. Just keep it as brief as Professor Collins' comment. Question?
Thank you. Thank you very much, Dr. Await, for the presentation, especially on capacity building. On my side, the capacity building, it's just like a commodity of which everyone should know it and use it to maximize individualism and customerism. Now, the capacity building, it's to put it in place, it's very expensive, but the sustainability of it is very low. What should be done to have positive sustainability at the social point of view, especially on the community level? That's what I'm asking. The other question goes to Dr. Kengia. Dr. Kengia, thank you for the monitoring and evaluation session. On my side, I can see in the public firm, we have more monitoring and low evaluation, but the private firms, they are high. They have a lot of monitoring and evaluation. Now, what can we do at the government firm, public firm, to put us on board in case of evaluation? Thank you.
Thank you very much. And the final hand? Yes.
Okay, thank you for the opportunity. I just wanted to share some lights from Aweti's presentation, especially in the area of partnership and collaboration and integration. Tanzania has some developments on the community-based surveillance. AMREF was a champion. We have championed the implementation of community-based surveillance since 2015. And now there is electronic system of capturing alerts from the community to the national level for the response. And even the alert for the Marburg was captured by the community health work, and it was reported in the electronic system. That emphasized the importance of having different partners in these forums in future so that we can share experiences and learn together. Thank you.
I'll start with the last question with my colleague from AMREF. Just to reiterate, the importance of partnership is critical. Also very happy to announce that we've just signed, I think you received yesterday the partnership document. We've just signed a partnership agreement with AMREF on rolling out interpersonal communication skills training for frontline workers and digitizing it to some extent and piloting it in some areas. So we do really look towards implementing this partnership. I think it's Tanzania and Ethiopia who are embarking on that, but also to use this as a lesson for the future. Not only to focus on immunization aspects of communication, but generally to look at respectful and effective communication skills for health workers that they can really deploy across different areas. I know the immunization program is highly funded and there are lots of donor-driven activities going on, but moving ahead, I think it's good for us if we shape that agenda together. So I just wanted to announce that. Thank you so much, Professor Collins, for your comments. I'll take that on board and look at the documents from the think tank as well and see how we can learn from that. There was one question regarding capacity building. If you could just maybe reiterate that. Was the question around, clarify that? Was the question around capacity building at community level?
Sustainability at
Yes.
the community level.
Thank you very much. Yes. So one of the reasons why we're bringing in civil society organizations, where we are bringing in the academia, and also looking at the various line ministries and looking at their skills and capacities for social and behavior change. We're still talking about SBCiE, and bringing them in through this capacity gap assessment and seeing how in the future we can leverage on their skills, expertise, because some of the capacity building that we want to do needs to be sustained beyond a one-off training or a one-off TOT that we want to do, but rather embedded within the different institutions that we have around the country, where we can roll out tailored social and behavior change programs at different qualification levels. So we've already, we know that when we've mapped about, I don't know how many, 20 academic institutions in the country. I still do not have the right number because I couldn't present it here because we have not completed the assessment as yet, but we have mapped about 20 institutions in the country, both in mainland and Zanzibar, to see on how we can leverage the various skills, capacities, and also the various platforms that they have to ensure that there is some form of sustainability that's also embedded there, systematically embedded, because it needs to roll out on its own. Yeah.
Thank you
Let
so
me
much,
just stop
Awet.
there.
Yeah, so we may not necessarily have the length of time to go into the nitty-gritties, but we have our session after lunch of meeting the experts. So you want to bilateralize with the experts should you not be satisfied with the brief response that they give us. Over to you.
Thank you very much. I just respond to questions. Number one is related to how can we engage other actors as during public health emergencies requirement sectoral coordinations. Yeah, that is very important, and I think we have an opportunity for now in Tanzania. Through the Prime Minister's office, we are developing the Health in All Policies guidelines that tackles all the key sectors that are very important for the health sectors. And it's not only a health in all policies guidelines, but there's a parallel monitoring and evaluation framework. So I see there's an opportunity there to also engage further and also include some of the issues of SBCiE. Of course, this one is also supported by WHO. Point number two was related to the evaluations, why in the public sectors is not vibrant. Yeah, of course, through basic principle for evaluation, usually you need really an expert and a professional evaluator. And most of the cases been conducted by the external experts. That's why maybe you don't see it much in the public sectors. But parallel to that, it requires some competences. And most of the cases, you need some research methodology aspects. And recently, we've conducted a research capacity in Tanzania, and they published a paper over there. Research engagement in Tanzania for public health sector institutions is less than 44% for most of the employees in the public sectors. So it's an area that we need further investment in terms of improving the capability in conducting research. And that will also uplift the level of the evaluation capabilities within the public health system. Thank you very much.
Asante sana. A round of applause to our two presenters, ladies and gentlemen. I might literally call them our two final presenters before we do the close-up. So let's give them a big one. You know the way this happens in churches mostly than in the mosques. The way, you know, when you're just about to finish mass and you're all smiley than when before you finished mass. I do not know why people go to churches. So please, if you may rise, so we take a picture in memory of our very great symposium. Our camera people are here. Now it's 2 o'clock. As I believe in democracy, I would like to say these few words, very few. If you all allow us to do another 1 hour before we go for lunch, so that when we break for lunch, it's meet the experts and we go home, or we go for lunch now, then come back and do the final hour. What do we all say? We finish up everything, yeah? You guys are the best, of the best, of the best. So I'm going to invite Fatma. Is Fatma up there? Did you share your bio? Did you? I don't have Ken's bio. So we're going to have the final presentation for the day, and then a series of question and answers. And then we're going on to the culmination of the symposium. But before we do that, or as we do that, part of that will be for us to receive feedback from you. What are your opinion? Do you have anything to say? Do you have anything to add? You probably never had the opportunity because we've been taking 2 or 3 hands, tops, 5 most. Would you have anything to add? But also, as we do that, we may probably not have the luxury of time because we've got to rush off for lunch. So may I request already some of us to put any comment, any observation in writing. I believe we all have some notebooks and pens. If you don't, Thai Tanzania will improvise. They're good at that, you bet. So we do that as I invite Ken. Let me see if I already have his bio. Okay, so Ken will introduce himself and take over the floor. I told him he has 20 minutes, but he said he probably could use fewer. So a round of applause. Ken arrived all the way from New York. New York, yeah? Yeah, this morning to be with us. Karibu sana. Do you want to use that one? Yeah, I think so. 20 minutes.
All right, thank you, moderator. Before I begin, I complimented him in private, but since I have the floor, let's give him a round of applause. He's one of the best I've ever seen. All right, so my name is Ken Lemwame. I sit in HQ team in health. I'm a specialist, but I'm embedded in health. So I lead the global SBCiE health agenda. Can I have the pointer is right there. Oh, okay. The big one is the next. All right, so the previous speakers kind of gave me a good prelude for my remarks now. M&D and Ebola is what got me into UNICEF and emergencies. In 2014, there was, as we all know, there was an outbreak of Ebola in West Africa. And what happened, even all the aid agencies, people were running away and there was no one to respond. And UNICEF was one of the organizations that decided to stay. And after analysis, we saw that the problem of Ebola was more behavioral or social than anything else. So this is a time when SBCiE was recognized as a key strategy in emergency programming. Even right now, a few years ago when we were combating COVID, it really benefited from the strategies that were laid, the background that was there because of Ebola response. So I joined UNICEF to strengthen SBCiE, C4D as we used to be called then, the research and M&D component. There was a whole social mobilization pillar that was established in Liberia just to design strategies, look at behavioral drivers, etc. Then in emergency settings, from then on, SBCiE has been part and parcel of any emergency thinking and implementation. Okay. All right, so the title of my presentation or remarks is just to forward thinking and forging ahead, future collective action through SBCiE in emergencies. Just to say in UNICEF, SBCiE is a change strategy, one of the 9 change strategies. We have program sectors and we have change strategies, and SBCiE is part of it. So SBCiE in emergencies is really a component or a dimension of SBCiE programming. And we don't look emergencies just as a separate component, but as part of a continuum, as part of the humanitarian development nexus, or peace nexus in context that there's fragile or conflicts. So how do we change behavior? I mean, the past 3 days has been, I mean, we've learned a lot, and I did like the naming of the symposium, high impact approaches. Over time, C4D, as we used to be called then, people used to look at SBCiE as something just to do with communication. But now we know we have to look at demand factors and supply factors in equal measure. We are looking at supportive public policies. We are looking at system strengthening. We are looking at social movements. We are looking at social listening. And the starting point is really behavioral analysis or social analysis. So use of data is critical in SBCiE. SBCiE being a multi-dimensional field, I mean, we do benefit from a lot of disciplines, but what we have to start from is really data. So we have to do analysis of political economy, analysis of different drivers, and also looking at risk-informed programming, you know, looking at the root causes of risks. So nowadays, we know climate change is linked to everything, and SBCiE is part of that agenda. So how do we change behavior? Changing behavior, here we're talking about individual behaviors, but we know behaviors do not exist in a vacuum. Behaviors are part of a context. And that's why we talk about social and behavior change. This is all, this is something that we all know, but it's very important that we keep on, you know, looking at these fundamentals. All right, so as I've said, part of the shift that UNICEF has done, and this shift has been mirrored across different organizations, is to move from information and communication approaches. SBCiE is more than just awareness, is more than just knowledge generation. But we're now looking at applying people-centered social and behavior change and science and insights. And this is just to repeat some of the points that Await made in her presentation. And for the past 3 days, we've looked at the use of social and behavioral science and data to understand why people do what they do and how we can influence it. It's very important to go to the core of it, like why, to understand the reasons why, because we cannot influence or change behaviors or social norms if we don't understand the why. But how do we get the why? We have to understand the hows and the whats. So SBCiE, I look at it as a science and also an art, and there has to be a blend of both, and each behavior needs to be studied. Studied, it means we have to understand it, the psychological drivers, the social drivers, the cultural drivers at different levels of the sociological model. We have to understand the behavioral needs and have to be addressed scientifically. And if you look at it as a continuum, on one hand we have social change, on the other we have individual behavior, and SBCiE is there, you know, looking at balancing changes from both ends. And we need, on one hand, we need social transformation, and on the other, we need individual change. And in emergencies, it's very, I mean, as I've said, it's a continuum, what we do in emergencies and what we do in development, because emergencies, we look at preparedness, we look at implementation, we look at resilient phase. This also builds resilience in terms of how development systems are strengthened. So it's really pretty much two sides of the same coin. Again, socio-ecological model, we're all familiar with it, but it's important to go to visit the fundamentals to actually look at all these different factors that interplay on different levels to understand what are the drivers on different levels. So this is SBCiE 101, but as we are closing, it's important to revisit the fundamentals. And at individual level, risk perception, if we are talking about emergencies, risk is critical, especially in public health emergencies. How do we understand risk? What's the perception of risk? And if you're talking about people-centered approaches, it means we have to understand what's the risk perceptions of the populations that we serve. And on the higher level, we're talking about individual and collective efficacy. We have to understand, and this is really the dimensional aspect of SBCiE. And also we have to understand social norms. So pretty much, I mean, I've seen in several contexts, people are doing emergency programming without really understanding, without having data, without having evidence. It becomes, it's on paper, we have to do evidence, but in practice, people do not take the time to invest in evidence. They design SBCiE strategies without looking at the drivers. So it's really, really incredible, important, and it's also efficient and effective for us to just look at the data. Otherwise, we'll just be shooting in the dark. It's very important to know what are the drivers we would like to address. Again, systems strengthening. So as I mentioned in our presentation, and I can't stress it enough, SBCiE has got a role in terms of strengthening systems, and because social and behavior change happens. Specific to public health emergencies, SBCiE, again, data collection evidence is a starting point, and also we have to look at digital engagement. So for UNICEF, we do have several solutions that we use, like RapidPro or Internet of Good Things, and also we have partnerships with private companies, say Facebook or WhatsApp. WhatsApp recently just granted us a whole community page to share messages for UNICEF Health. So these partnerships are critical. So private sector is important not only in terms of resource mobilization, but also as partners, as collaborators in emergency programming. Again, people-centered approaches, this can be emphasized enough. Community trust, we are here, trust is important. It's the currency of everything we do. If trust is broken, there can't be any collective action. So, and there's a recent study in Lancet that says levels of trust in a country have got statistically significant influence on infection rates than any other indices related to health security. So these claims that we make, they're not just wishy-washy. There's something that we've strengthened, that's strengthened by data. And this is what we are doing as UNICEF. We are really investing in data to convince some of the people who doubt the effectiveness of SBCiE approaches in terms of effectiveness, but in terms of even costing, that SBCiE is not something that you have to look at an afterthought, but should be integral to any emergency planning and programming. We've had good sessions today on knowledge management, on tacit and explicit knowledge, and this interaction has been good for tacit knowledge. This is something that you can't codify. This is something that just interaction with the experts in the room, I've just learnt a lot. And imagine if I was here the entire time. So this is the value that we do have as SBCiE to public health emergencies. So we can achieve increased quality of public action. How does social change happen? We have to reach those tipping points of change. And this cannot be done by one actor. It has to be a society-wide approach. So SBCiE can achieve that quality, and we can increase health system resilience. We can also increase community resilience. So moving forward, we're looking at communication to improve the delivery of information to ensure accurate risk perception, promoting behaviors and that reduce risk and enhance resilience. We're looking at supporting and have resources to individuals and communities. To enable them to take appropriate actions. We are looking at, I don't know what's happening with technology. Yeah, we're looking at engagement of communities in emergency planning and response. with focusing on AAP to increase collective efficacy and promote a sense of ownership and responsibility, and importantly, learning. This event that we've had this week shouldn't be a once-off. I had a conversation with Aweti, like, okay, do we have any ideas to make this routine? But it's not yet finalized, but it's something that we have to, again and again, at different levels, convene and learn from each other. So thank you very much. Yeah. Yeah, okay.
Yes. And to guide, thank you very much, Ken. A round of applause. We are totally grateful, even for the thought that this has just brought up so many food for thoughts that really need to be cascaded forward. So I believe those responsible, we have MUHAS, we have UNICEF, and all the stakeholders. We ought to really keep the ball rolling. So thank you so much for that thought, and to bridge you through the next session, which is Q&A from the audience. 2 questions. I will invite Dr. Dr. P to guide us through the Q&A session, and then she will sort of like wrap up, and then we have Muhimbili for the closure. But before we do that, I will have then the session whereby we all contribute, we all say something about the session. Dr. P.
Thank you, MC, and thank you, Ken, for that insightful discussion. Colleagues, questions? I would like to take 2 or 3, if Austin allows. 2? Okay. Any questions? I don't see any hands. Yeah, okay, great. Thank you, Stan. So I'm just going to complement by just saying, yeah, you can sit. Yeah.
No, we have to, yeah, just stay there. Okay, all right.
For the photo. I think it's for the photo, but it's fine.
There's a question.
There's a question? All right.
Oh, sorry, I wanted to give other people also a chance to ask because I've been asking. So thank you very much for a very good presentation. In your presentation, I have not heard you highlighting on the role of the social determinants of health in informing and the designing of the social behavior change communication, because we understand that all these things emanate from the way we understand and appreciate the social determinants of health in designing our social behavior change design, because to be able to induce a sustainable behavior change, we really need to appreciate the social determinants of health. So what is your take on this? Thank you.
Yeah, it's just one question.
All right. I agree with you. So when I talk about evidence and action, it's not just like surveys. You're doing analysis on the social determinants. You're doing policy analysis. You're looking at the entire picture across the socio-ecological model. So if you look at the outer cycle of a socio-ecological model, this is the legislative or policy environment, and what are those macro factors that affect individual or social behaviors. Yeah. So I agree with you. We have to look at what are the social determinants of change. And again, UNICEF also believes SBCiE is not only at changing behaviors, like individual behaviors, but also how can we influence, like those macro factors. So issues of equity, issues of inequalities. That's why we're now embracing social movements as part of the, part of the approaches, because some of these changes require a collective action and to reach those tipping points. Yeah, thank you.
Great, thank you, Ken. There are no other questions, so I'll just proceed to wrap up on behalf of the technical organizing team. Colleagues, we are so proud today to announce that this undertaking of the symposium is coming to a closure, and we have our partner MUHAS coming through with the closing remarks. But I just want to say a few words in terms of what we have managed to achieve so far and how definitely we would like to see this going forward. So one of the first things I think that I want to focus on is the partnerships and forging synergies. I think we have seen that in terms of partnerships, we are doing so well around social and behavior change in emergencies, but now is the synergistic component that we really need to continue building and see how best we can have an additive impact in the work that we do. The second aspect also that I just want us to continue also thinking about is how we can take also the work forward from the systems thinking and modeling that we have done. We know social and behavior change, being multi-sectoral, has many components which behave differently when they are tackled also differently. So the modeling and the dynamics thinking is the work also that we need to continue looking at in line with advancing social and behavior change in emergencies. And then financial impact analysis, I think Ken mentioned something about it, but it's also something that we really need to look at. We always commit a lot of resources for social and behavior change activities, and how then can we also, as part of accountability, ensure that what we put in the community creates also a lasting legacy around the work we do. And then also something to think about, it is better to own than to know. The cultural nuances that we have are being very rich here in Africa in terms of heritage and other social norms and cultural dimensions. How do we continue to position that aspect, especially to leverage upon it during emergencies where situations are also dire and dynamic? We have also seen from the presentation from artificial intelligence, I think it is good that here in Tanzania we have started to embrace the 5 streams around artificial intelligence, but I think it is also work that we need to continue building it, knowing that we cannot run away from it, but we can utilize it at an advantage. And we can see also how we have managed during this symposium to not only reach participants in Tanzania, but also participants globally. We have about 35 countries following us online, and that is the power of AI, that is the power of digital systems. That is something that we definitely need to continue leverage on as we share our best practices. And then I will just mention something also around, if you look at our auditorium, I would like to think that we've done justice to our thematic areas and the icons that we have. I hope participants had a chance to interact with our icons, evidence generation and data analysis. We covered so much ground. Systems dynamics and partnership development, dimensions around scalability and sustainability. The work that we do is emergency, but that humanitarian development nexus, how do we continue to tie and close the loop to ensure that we also continue to touch on resilience issues. And of course, today we had a very interesting session on social accountability, equity, inclusion and exclusion of key populations. How do we take that work forward, especially in emergencies, and what are the limitations? How can we go around those limitations? So I think you can see from what we have tried to do in this symposium is just to try to put the pieces together around emergencies and, of course, really tease out the novel applications, high impact approaches that we have done here in Tanzania and shared with the group. So I would really like to thank you, colleagues, but please allow me before I leave to mention the technical team. We had not had a chance to even mention them by name during the 3 days. Yeah, we have Dr. Chi. Please just, you can stand. Yeah, Dr. Chi, our senior health systems specialist, she was really part of the team from the beginning. We also have our colleague, Dr. Mohamed Hussein from MUHAS. I know Dr. Lulu Makene, she just stepped out, but she's from UNICEF. She was part of the team. Terence, I think he's running around, yeah, but he was also part of the team. I know the professors, please forgive me, I'm going to mention you, and I think Austin will also ask you to come to the front. We were flanked by 3 professors along the journey. We have Professor Gasto from MUHAS. We have Professor D. Munodawafa. We have Professor Collins, Hivenboa. And then, of course, our very own agile and technically sound chief, Awet, please. So yes, and not forgetting myself, of course, as I was right in the center, putting the pieces together. So yes, Austin, thank you so much, and back to you.
So I wish we had a very good picture so we can. I'm not sure the event organizers. Who? Evelyn. She should be outside. Can we squeeze out? I do not know. Is our bill out that there to switch us? Oh, we're back. Okay. So please just squeeze in. We have a very nice centerpiece. Yeah. So let's give them a big round of applause, ladies and gentlemen. You know, they saw this as a possibility, and okay, so Evelyn will be represented by Mercy. No? No? Did you say no? And Ken, if I can ask you to stand on Awet's other side, yes. And Professor from MUHAS as well. If I can ask you to stand. Dr. P, if you can go in between the 2 gentlemen. The first 2. Last time I checked, Professor Wafwa likes to be in between ladies. I do not know what is not going on today. Prof, if you can Prof, if you can go in between Awet and Chi, please. Yeah, you see even the skin complexity resemblance, eh? Okay, so this is a very good picture. Let's give them a big round of applause. Before it was just an idea, and it's come to reality thanks to you very much, and to all the partners, and to everyone who participated on this very wonderful symposium. It's very difficult to believe it's come to an end, really. But again, thank you all. So you may take your seats back. Thank you so much. You're hesitating. You look like you want to stay. I would allow you to stay. Okay, so let's spend a couple of minutes just to allow anyone who has any opinion, any contribution, before I invite MUHAS for the official postponement. As we agreed, we are not closing, we are postponing it until further date. So if there's any comment, any opinion, any observation, it's now or never, and forever hold your peace. There's a hand, Professor Godfrey. Dr. Godfrey, sorry, Dr. Godfrey. Secretariat, I believe we are grasping, we are taking the notes. I've seen your hand, we'll come to you. Thank you. Professor, please, Doctor, please proceed.
Yeah, thank you very much. I think congratulations to all the organizers and to all who contributed in one way or the other. I think it was great. It was really very rich and insightful. My observation, I don't know if I'm right or wrong, but I would have wished to see more programs here. Programs, I mean, like health, like WASH. As I said in my own presentation, I think C4D is a pillar to all of these programs, and they cannot pretend that they can achieve anything without SBC. I'm wrong or right, but from other experiences elsewhere, usually they are left alone. SBC is left alone to do their own thing, and yet we would like to see more engagement and more partnership. Thank you.
Thank you very much. I think it's a very valid point. We would like to, what basically Doctor is saying, and I believe I'm reiterating correctly, we would like very much to learn more from the programs. You've mentioned WASH, among others. So I think we've taken that, and certainly for consideration in the next session. There's a hand. I want everyone to speak. This is our symposium, you know. It's not for the speakers and moderators and a DJ who is an MC and an MC who is a DJ with music. No, please, let's all speak.
Yeah. Thank you very much, and I really appreciate this session today. I missed the 2 sessions, but by coming today, I've been able to learn a lot of things. So my contribution is that I was trying to reflect on how perhaps we can enhance the approaches that we use in our social behavior change communication to ensure that there is an inclusiveness. And actually, this begins with the approach that we use. Because sometimes we may assume that everybody is included in the process, while the approaches are actually embracing exclusion of some groups. So this is my small contribution. Thank you.
It is never small, it is never insignificant. They say if you do not know how significant your contribution is, think of a mosquito, how tiny it is, but it gives a headache to all. There's everyone here, I believe, has had that pinch of a mosquito. So it's never insignificant, it's never small, it's truly appreciated and taken. Thank you so much. Any other contribution? Any other hand? Yes, ma'am.
Thank you very much. Congratulations. This is a great achievement. I'm not so far from others. I just want to remind you next time to have a broad inclusiveness without forgetting the traditional healers, farmers, and all of the field, because as you know, the SBC cuts across, so we could have a more big number of representatives. The other thing which I want also to say here is about it's about way forward to have the plan and the work plan and the way forward for the key things which will arise, which can also be displayed for the future symposium, and try to see if we have managed to work on it. One of it is also including the university students. The other thing is thinking of including the SBC in the program, in the curriculum program as a way forward. Also, I would like just to nudge the board by having the light, the green light, which will be controlling the time, instead of asking how many minutes is left. If you could have the green, the yellow, and the red, that can alert us and make us more up to date, together with having just a portion of displayment of maybe of the agenda, objective, or whatever of the session which will be ahead of us. Thank you very much, and congratulations for this achievement.
Asante sana, thank you so much. Some of your points are very pragmatic, and we'll certainly consider them for the next session. I've seen Evelyn walk in, so we'll request when we are done, we take that group picture again, okay? And of course, the screen is back. When you're taking the picture, it had gone off. I think he did an early lunch break. Mom, over to you. Yes.
Okay, thank you. Let me join the previous speakers and thank all the organizers, UNICEF and all the collaborators for this well thought idea and well implemented that they have brought us together into advancing the social and the behavior change in emergence through high impact approaches that we form effulgent synergies and partnership to deliver social and behavior change in emergencies at a scale. But not only that, but also to ensure that it is scalable, sustainable, and replicable. This is really wonderful. So what I want to contribute is that through the last 2 days, we have heard on the importance of engaging the communities. We have heard about the importance of social and the cultural issues and the backbone into the success of all that we have discussed. So let's take it at the back of mind that we should, I remember Professor Paul said that we should really not praising ourselves that we will go down to the community. That also assumes we are higher than the community members, but that is try to work with the communities, to be with them, to be us without what we are doing, so that we are working with the communities, we work for them and for their benefit. We should also remember that diseases are really emanating from the communities and they are finishing the communities. So the communities are key in whatever that we want to do. If we really want to understand the dynamics and the patterns for the disease causes and how the communities can be empowered so that we are all creating a better life for all. And on top of that, I was triggered to talk after my colleague spoke about having a curriculum for social and behavior change. At MUHAS, we have a program, a postgraduate program that is going to, actually it is ongoing, but we revised the curriculum and we have taken into board most of the issues that have been discussed here. And it will be offered from next year, Master of Science in Behavior, in Social and Behavior Change. It's going to be a 2 years program. So please, you are all welcome. It's going to be very interesting, very enjoyable.
Thank you very much. Wonderful submissions. Asante sana. Yes, Mom. Karibu.
Sorry.
I will take 4 last hands, okay? And we proceed for the closure and lunch. Yes, Mom.
Sorry for lagging behind. I forgot I was just looking at the RIMO, but on behalf of the RIMO of Dar es Salaam, RHMT and CHMT, thank you very much for conducting this symposium in Dar es Salaam and give us the room to participate. We are looking forward to have the same symposium maybe in Dar es Salaam again or anywhere else next year. Thank you very much.
Thank you very much. The people from Zanzibar will definitely be looking at you. Like, we also have hotels and good conference facilities in Zanzibar. So the organizers, for your consideration, thank you so much, but they've taken it. Thank you very much. There's a hand from a gentleman. Last 4, yes. Karibu.
Moderator, maybe mine is you want to add on the upcoming symposium, we can extend our invitation also to include colleagues from the One Health platform. You know, we have the colleague from livestock, wildlife, animals and the environment, like the animal health and to capture animal health and public health, plus the environment, as we know that almost 70% of diseases or outbreaks, some of the outbreaks originate from animal. And so it will be an opportunity to bring together experts from all those relevant domains. Thank you.
Absolutely. Did you say 70%?
Yes.
Wow.
We have our colleague in Arusha, they have also a scientific symposium on antimicrobial resistance. So one of the issues is how do we tackle the antimicrobial resistance through One Health approach.
I only thought mad cow disease is the one that could pass from cows to human beings. I didn't know many other things, so I'm grateful also to have learned that. So thank you so much. Organizers, kindly consider that next sessions we are leaving no one behind. Thank you so much. Professor Collins, we'll come to you.
Thank you, and let me add my vote of thanks to the organizer and to you, Mr. Chairman, for keeping us on track and for a very successful meeting. Dr. Priscilla and the team, thank you for your hospitality welcoming us. You know I'm a storyteller, and one message that I would want to leave you with first is to always remember that at the height of decolonization, it was Mwalimu Nyerere that said, you cannot develop people, you must allow people to develop themselves. And that is a recurring theme in what we are talking about in terms of how you engage community. That the power to change is actually in your hands. When we talk about that house to home, you have it in your hands. And I would end with a story that was shared by the American Nobel laureate, late Toni Morrison, upon the acceptance of her Nobel Prize for Literature. She told a story that is told in different way, in different contexts, but here I'm going to say, use Tanzania. So it's a story of a woman, an older woman, that lives at the outskirts of Dar es Salaam. The woman is blind, but she is also reputed for being very wise. So much so that people accuse her of being a witch, and in fact that was how she got pushed out to the outskirts of town. So there's some young people decided that, you know how young people play prank, they're curious about things, so they said this woman is wise. We're going to go see how really wise she is. So they gathered themselves and went to the woman's house. Knocked on the door, pushed their way in, and the woman is standing there. And they said to her, the leader of course, all the while sort of laughing and giggling, and said, so old woman, we hear that you are wise, and you know everything. So tell us, I have a bird in my hand. Is the bird dead or alive? Tell us. The woman is quiet. He's not saying anything. And then he repeated himself. We say, tell us, old woman, we hear that you are wise and you are smart. Tell us, is this bird dead or alive? And after some pause, the woman said, I know you are in front of me. I don't know if the bird is dead or if the bird is alive. What I do know is that the bird is in your hands. The bird is in your hands. The SBCiE bird is all of your hands. Thank you.
Thank you very much. The art of storytelling, powerful. Thank you so much. Doctor, I believe.
Yeah, thank you very much, moderator. I also join hands to congratulate and thank the organizers and the sponsors of this very important symposium. It says social behavior change in emergencies. It's very important for keeping the society healthy, for achieving better health outcomes. In fact, I was even thinking out of curiosity that maybe in the future we may think think of extending this to combating, applying the similar principles to combat the NCDs, non-communicable diseases? Thank you very much.
Totally, thank you very much. It's a very valid point. Can I have okay, Professor Wafa, and then can I have one contribution at least from Zanzibar to say something? So Zanzibar, amongst yourself, pick one person who will say something. Thank you, Wafa. Over to you.
Thank you very much, our MC, and I also would like to add my voice to congratulate the organizers, the partners, all those who contributed to the success of this meeting. More importantly, the participants who came to contribute. I know our esteemed chair, or moderator, chair, what is your real title?
Moderator. All of the above.
Yes,
A and B are both correct.
I remember you imploring all of us to try and say something. And I think this is also part of what you want to achieve.
Yes.
That each one of us says something. There is a saying in my country, if you came to my house or to any gathering with a covered dish or basket, and I see you walking out at the very end with the same covered basket or dish, we become very suspicious.
Of course.
That what is inside? Why? Maybe you're talking of witchcraft and other things. Maybe they didn't find their targets. I think that's what you're trying to encourage us to say something, to contribute to this, and I think your facilitation was really excellent. I wish I could market you or take you somewhere. Now, in terms of why we came together and what we wanted to achieve, I would like just to add one dimension, and I understand the way this meeting was set up as a symposium, but for it to gain more depth, more traction, more width as we go forward, I think it would be very, very important. Among the voices that I've heard colleagues advocating that they should be here, there are organizations that should participate, I think we need to hear the voices of those whom we seek to support or help, and these are the young people themselves. I know that UNICEF is the overall mandate on this group, and they will do a good job. But I think to take this kind of meeting forward, we will need them. We don't want to sound like we are afraid of them. I was at a meeting in Kenya at the Bomas. On the last day, the organizers thought they really had everything and invited the child president, a young guy called Mwangi at the time, I don't know where he is now, and they asked him to come to this closing session. And we had been there for 4 days. And when Mwangi was called as child president, he said, "Thank you very much, our elders. We're very happy that you have invited me to speak on behalf of the young people, but I hear you have been here for 4 days talking about us, and we're not here. And now you want me to say something when you are closing. Are you afraid of us? We are your children, and we look up to you." I just want to build this kind of sentiment, and I know that this was a program, sort of programmatic meeting where people were involved, different partners involved at the program level. But we don't want to miss this. There's a lot of wealth and insights into the problems we are trying to solve. Until we go to them, we may continue to talk among ourselves. Thank you very much, and best wishes. As we'll be available. Also like to invite you to my country one day if I find something.
Be rest assured, I will come, but not with a closed basket or pot.
Very open.
Very open.
But full in the beginning.
Absolutely. So thank you very much, Professor Wafa. It's truly an honor and compliments received. Thank you very much. Zanzibar, you want to close this up? Thank you so much.
Thank you very much. On behalf of my colleague from Zanzibar, thank you for UNICEF and Mwembili for giving this opportunity. We learned a lot of things, especially in SBCiE. From that symposium, we have a lot of challenge and improvement through this initiative. So we're going through it at least to improve our knowledge and other issues related with us. Thank you very much.
Asante sana, Team Zanzibar, well done. So my very final announcement, probably after the closing remarks, I'll only come to announce the parting song. But at the back of our badges, there's a QR code. Okay. So up to now, they are still uploading the pictures of everything that transpired here. I believe as of Monday or sometimes next week, all the presentations that were made could also be found through the same QR code. Okay? It's just behind your name tag. So please go back to your name tags, scan the QR code to view all the wonderful pictures, including Professor Wafa doing the dance moves on his 75th. You're 76 next year, yeah? You were 76 yesterday. Yesterday you were 70. Today, we'll definitely sing for you happy birthday, Professor Wafa. So, distinguished participants, allow me to invite from MUHAS, Professor Gasto, who is the Dean of School of Public Health, to honor us with the closing remark on behalf of the Vice Chancellor of MUHAS. As he comes down, let's put our hands together for him. Asante sana. Tumpigie makofi basi. Let's clap for him.
Thank you, moderator. Dear country representatives from different UN organizations, including UNICEF, WHO, USAID, CDC, UNFPA, and the other UN agencies, all representatives from government. I know that we have different representations from government ministries. You are all recognized in these closing remarks. All representatives from implementing partners. I understand that we have several implementing partners in our symposium. Keynote speakers who are here, panelists, representatives from non-governmental organizations and the private sector. Ladies and gentlemen, esteemed guests and fellow participants, good afternoon. It is my honor to stand before you as we are about to postpone. As MC said, we are postponing, we are not closing this 3 days symposium on advancing social and behavior change in emergencies through high impact approaches, forging synergies and partnership to deliver SBCiE at scale, connecting for impactful change. Ladies and gentlemen, we have the program which show that in our symposium we had 5 thematic areas, and I think Dr. Priscilla has said a bit about what we have discussed here, but I'll just take you through a few issues that we discussed in very brief about the 5 thematic areas that we have discussed. The first one was about evidence generation, analysis, and use of data in making informed decisions. This was an important thematic area where several presentations were made, and it is in this, I remember we also learned a lot about the past public health emergencies and disease outbreak. We also discussed a bit about behavioral science and its application, use of social cultural anthropology to bridge the evidence in SBCiE, the role of information, which I think Dr. Priscilla has talked about, and the artificial intelligence in our intervention. This is very important area that we needed to venture into. And the second theme, ladies and gentlemen, was on the, thank you, was on the development and dynamic of partnership and institution inclusion, and in SBCiE, in which we shared the experiences and best practices on partnership and synergies in different interventions. We learned a lot about how to partner effectively towards advancing SBCiE. I think this also was very important discussions. We got a lot of insightful information. The third thematic area, ladies and gentlemen, focused on unveiling the discourse of culture and the nuances in systematic differentiation of SBCiE in Africa. And in this thematic area, among other things that we discussed is about the role of culture and the linkage and the strategies on crafting evidence-based, compelling, and cultural sensitive content in SBCiE during public health emergencies in our continent and maybe beyond. And the fourth thematic area centered around the discussion on how to ensure scalability, sustainability, and replicability of SBCiE. Ladies and gentlemen, under this theme, we discussed issues related to how to enhance collaborations and coordination on SBCiE, which I'm sure the information that the discussion that we had in this particular thematic area will help us to address some of the challenges, especially when it comes to coordination and collaboration in various interventions that we are implementing as partners. And we know one of the issues or challenges that was discussed here is about duplication of effort. So the issue of coordination, I think, was very important, and the comments and recommendations that we obtained in this particular symposium will actually help us to address some of these challenges. Ladies and gentlemen, the last thematic area was about social accountability, conceptual dimension and operational modality during SBCiE. I think this was a very good discussion that we had today. The focus was on the role of social accountability, dimension, modality during the implementation of the SBC interventions. More importantly, we had a presentation on rethinking the inclusive exclusion of people with disabilities. I think that was also a very good presentation when we manage public health emergencies. How do we include the excluded population? And we got a very good example from the COVID-19 response at the community, citing an example of the deaf community. We also, under this last theme that we discussed, there was also an issue of M&E, and I think this was seen to be very important. How do we monitor and evaluate our interventions? I think this was very good presentation, and we needed to look forward on how we are going to monitor the interventions from the community level to the national level, but also evaluate them to see the outcome and not the output as the presenter talked about. But we also talked a bit about building institutional capacities. I think this was also very good presentation and discussion, which we are looking forward to see how this is strengthening, so that different institutions, different stakeholders who are involved in SBC interventions can have the capacity, the required capacity and capabilities to be able to effectively effectively implement the interventions. But lastly, we discussed a bit about how to change people's behavior, and this, I think, was a very good presentation for our colleague. Ladies and gentlemen, I think we had very wonderful 3 days where a number of presentations were made and very insightful discussions. People were very interactive. We really enjoyed seeing people discussing and interacting in this symposium. Ladies and gentlemen, I'm sure that the 3-day symposium has provided an insightful information regarding we are talking about advancing social and behavior change in emergencies. So this, I think, to me, I feel like we have done very good justice to these themes that aims at advancing social and behavior change in emergencies. And I hope that the lessons that we have learned from this symposium, but also the recommendation that we have received a number of recommendations, including the last session that our moderator has just finished. I think that was also a very good session. So in those recommendations that we have received, ladies and gentlemen, it is my hope that we are going to use them to strengthen the SBCiE systems so that at the end we will be able to improve the implementation of the SBCiE interventions in our country and beyond. Ladies and gentlemen, the School of Public Health and Social Sciences, MUHAS, take this first symposium as actually the beginning of a long journey, because we see we have a long journey ahead of us. So we take this as a stepping stone where we are going to share more knowledge in the future, and we are going to disseminate information with regards to implementation of public health emergencies in general, but more specifically in SBCiE. As one of the presentations was made on knowledge management, I think that is our vision, that is our dream, that the School of Public Health should be a center where people will be able to disseminate, to share knowledge with regards to public health emergencies in the future. Therefore, let me take this opportunity, ladies and gentlemen, to extend my heartfelt gratitude to UNICEF. Thank you very much for agreed to partner with the School of Public Health and Social Sciences to organize this important symposium and provide financial support for this symposium to happen. Otherwise, if it wasn't UNICEF financial support, ladies and gentlemen, this symposium would not have been done. Let us give them a round of applause for supporting us financially, but also for joining efforts with the School of Public Health to organize this important symposium. Thank you very much, UNICEF. That is not enough. Can we do it systematically? At least 3 big hands, please. Thank you very much. Ladies and gentlemen, I also wanted to take this opportunity to sincerely thank our esteemed guests who have graced us with their presence in this important symposium. As keynote speakers, I think we all know that sparing 3 days here, it's really, for us, we really value it. It means a lot for us as organizers. So we really appreciate for sparing your valuable time and come to take part in this important symposium. Some of you have traveled long distance all the way from USA. We know that, from South Africa and the other countries. We really thank you for that. We know others are also coming from the regions, many from the regions outside Dar es Salaam. We really appreciate, but we also appreciate those who are also coming from Dar es Salaam, including those who are coming from Regional Health Office. Yesterday or the other day, I think I heard that we have RHMT members in this room, but we also have representation from ward and street level. We have CHMT and the street level. This is good. This is really good. When you work, in most cases, when we organize such kind of symposium or conference, we forgot people who are coming from the grassroots level. I wish in the future that when we organize such kind of event, we include more representation from the community level, because there is where actions take place. When you talk about changing people's behavior, those are the people who help us to make sure that people really change their behavior and we have the health populations. So thank you very much for the keynote speaker, and we really needed to give them a very warm round of applause. Ladies and gentlemen, let me also thank all the participants of this symposium for their active participation. We have been here for 3 days. I understand that we have participants from UN organization, implementing partners, government representatives, as I said, both from Tanzania, mainland, and Zanzibar. I'm also aware that we have representatives from the regional health office, as I said, and community level. We really appreciate for their participation, and we hope that next time when we invite them, they will be part and parcel of our symposium. Ladies and gentlemen, it is my hope that we have already talked about the organizing committee, and without organizing committee, Dr. Priscilla called it a technical committee. So it's technical committee, it's organizing committee. They have done a wonderful job. And I want to use this opportunity really to appreciate and thank them for taking time. It wasn't really an easy job. It has taken more time than we expected to organize this. And we really appreciate for your time, but we really appreciate for your commitment. And I want to assure you that this symposium has been successful. So let us really give them a very warm round of applause for the good commitment and the work that they have done. Last, ladies and gentlemen, but not for the importance, I want to thank you, the moderator. He has made us, very active. We danced. We go to some of the symposiums or conferences, we never dance. But some of us, we also learned to dance in this symposium. Thank you very much, moderator. I think we really appreciate for the good job that you have done to make this symposium a very interactive one, and we really appreciate for that. Let us applaud him. Thank you, ladies and gentlemen. I think people are hungry. It's now time for it to postpone. So may I now declare that the symposium titled Advanced Social and Behavior Change in Emergencies through high impact approaches, forging synergies and partnership to deliver SBCiE at scale, connected for impact, is officially postponed until next time when we organize similar events. Thank you very much.
So may I request the team that was here before to come and take the group picture with the Dean on behalf of the VC. The organizers who were taking the picture here before, to please come to the front. Awet, Priscilla, the professors, Chi, Evelyn, are you here with us still? Please come down. And as they come down, I have one announcement from UNICEF. Facilitation will be made through your mobile phones. Facilitation, I think transport and logistics will be made through your mobile phones. So keep your lines on, and you shall receive your facilitation through your mobile phones. But I would also like to reiterate, those coming to Dar es Salaam, or those visiting Tanzania for the first time to please make the best use of your remaining time in Tanzania and in Dar es Salaam. We have the finest beaches. We have beautiful places. Zanzibar is just 15 minutes flight, 1.5 hours cruise. Beautiful Zanzibar. We have Bagamoyo, just 1 hour, 1.5 hours drive. I'm still seeing a few people missing. Professor Collins is supposed to be here as well. Who else am I missing on this picture? Priscilla, who am I missing? Other than Hussein is stepped out, but Evelyn, I saw coming up. She's coming, very good. Now can we get mixed a little bit? You know, we have gents looking like gents and ladies on their own, like we are doing some Friday afternoon prayers. Yes, Awet, if you can come in between the two gents, although protocols, and Evelyn. Yes, Evelyn, you can stand on the far right, far left. Far left, that side, the other side. I will not comment. So, as I know some of us probably already on the holiday mood, this being probably this is the final symposium for the year to as far as social and behavior change communication in emergencies is concerned. I'm going to part us with a old holiday song, and this will then take us to lunch. And then I'm told that Meet the Expert session is not on, so please make sure the person that you are having lunch with adds that final value before we all part. So after lunch, please feel free to proceed on your own programs and agenda. Thank you very much. DJ, the last final song for the symposium. Thank you so much.